Hur vet jag när det börjar då? Ja. Okay. So have you all found your seats? And we will start. So a warm welcome to all of you present here today, and also to the internet viewers. I'm very happy to see so many of you here, and we have a couple of hours of interesting talks ahead of us. So my name is Kerstin Sollerbrandt, and I'm the head of the Department of Research and Education at the Swedish Childhood Cancer Foundation, and I will be your host here today. We are sending this meeting live today, and the presentations will also be uploaded on our homepage later on, so you can see it over and over again if you want afterwards. We call this meeting Hopp Framsteg, which could be translated to hope and progress. This is an annual event where we invite researchers with funding from the Swedish Childhood Cancer Foundation to talk about their work. This year's meeting, however, is special in many ways, and the reason being is that it's being held in connection with the annual meeting of NOPO. NOPO is a society of physicians and researchers field of childhood cancer, mainly from the Nordic countries, but recently also from Lithuania. The last couple of days, this room has been full of great talks by national and international speakers. And we have the great pleasure to have some of these well-known researchers here today to give a popular science presentations of their field of expertise. And before I present the speakers, I would like to shortly present the Swedish Childhood Cancer Foundation. And here is that. So, the Swedish Childhood Cancer Foundation is a non-profit association entirely funded by generous donations from private citizens and companies. The vision of the Swedish Childhood Cancer Foundation is to eradicate childhood cancer. We are the main funder of childhood cancer research in Sweden. And since the foundation was founded in 1982, we have allocated almost 2 billion Swedish crowns, which is approximately 0.2 billion euro, to research. And this is what we do. We have 3 main missions, and these are research and education, which is the largest mission. And we also have counseling and support for families and the patients. And we also inform about the disease, and also to make the general society more aware of the problems that face our patients and families. We have donations from private citizens and companies, very generous, and you can see the trend over years here. So it's increasing, and it's still increasing. So in 4 years, we have actually doubled the money that we have been able to raise for research and our other 2 missions also. So that's promising. And of the 32.7 million euro that we allocated last year to our 3 missions, the majority goes to research and education, so 33% goes to that mission. 16% we allocate for the mission of information, and 11% goes to counseling and support of the families. When it comes to research, we have also seen an increasing amount of money that we can actually fund research projects and other projects over the years. And as you can see, the trend is similar to the amount of money that we raise. So the more money we raise, the more we can actually fund research. And that is, of course, what we want. And last year we allocated 238 million Swedish crowns, 23.8 million euro, to research and education. And of this sum, we have allocated 79% to research, what we actually call research projects. But actually, we don't finance only research. We also have a major projects within infrastructure. And we also have education for nurses and for doctors within the area of childhood cancer, and 3% with other things like development of IT technology and so on. And today we have 112 research positions that we finance. They are from or different seniority, so everything from a couple of months for a clinician to be able to do research and up to 6 years position for full-time researchers. And we have currently 235 different research projects. And these research projects can actually be applied for from the other Nordic countries, researchers from Nordic countries as well. We participate in infrastructure, and the two biggest infrastructure projects that we fund is the Swedish Childhood Cancer Registry, which is known, I think, to most of the NOPO members, which also use it. There are international or Nordic part of this registry. We also fund the National Biobank, which is very active, and it's giving promising results. And we also partly financing the Hopp Clinic, which is an European center for early clinical trials in childhood cancer. And finally, we also perform education and training for doctors and nurses, which is very important. And I think the people that participate in these courses think it's very good that they have this, especially the nurses, so for further learning. But the question is then, what can we do more? So in Sweden, more than 300 children are diagnosed with cancer each year. And childhood cancer is still the most common cause of death for children between 1 and 14 years of age. And more than 10,000 children survivors exist in Sweden, 60% of which develop late complications. So there are more things that we need to do. And the two most important missions that we have and things that we have to accomplish is to increase the surviving rates. In this presentation, you can see the survival curves for the different diagnoses in childhood cancer. And now approximately 80% of the children are cured. However, there are still 20% that actually don't survive. And that is one of the most important tasks for the future, of course, is to increase the survival to 100%. And for those who survive, we also want to participate in creating a situation where there are no late complications and no late effects from the disease. And how we will do that is something that we will discuss later in this panel discussion at the end of the talks. Now, it's time to have the first speaker. and that is Gilles Basal. And I would like to encourage the audience, both here and online, to take the opportunity to ask questions to the speakers at the end of their presentations. The first speaker is Professor Gilles Basal from Institut Gustave Roussy. You have to help me to pronounce it. And Gilles has dedicated his research to the development of new drugs for children and adolescents with cancer. And the title of his talk is How to Accelerate Therapeutic Innovation for Children and Adolescents with Cancer. Please.
Thank you. Good afternoon. First of all, I would like to thank very much the Barncancer Foundation for the invitation. I'm very pleased and honored to be here today and discuss with you where we are and where we want to go to be good and help more children to be cured of cancer. So what I would like to do is just to update you where we are at the moment in the implementation of the SIOP strategic plan. What is SIOP Europe? SIOP Europe is a European Society of Pediatric Oncology encompassing all European clinical trial group and national societies with 3 missions: care, research, education. And in 2015, in November, we launched in the Parliament our strategic plan for the next 10 years. What I would like to do today is share with you what are the objectives of this plan, where we are, and what is left to do, to show you there is a real momentum at the moment in the community, in partnership with parents and survivors, to really improve the outcomes of children with cancer. At the moment, there are 35,000 young people each year diagnosed of cancer in Europe. And with the current treatments, which have been developed over the last 50 years by the community of pediatric and oncology and hematology, 80% of them are disease-free at 5 years, thanks to the multidisciplinary treatment with surgery, chemotherapy, and radiotherapy. Which means that at the moment in Europe, there are 300,000 citizens who are childhood cancer survivors. And we know that 2/3 of them have consequences of the disease or the treatment on the long term. But on the other hand, it means that each year, 6,000 young people die of cancer in Europe. As I mentioned previously, it remains the first cause of death by disease in children over the age of 1 year. And the strong message today to the community, to the decision maker, is cancer, despite major success over the last 15 years in children in terms of treatments, is still a public health issue. These are the results of a paper looking at registries across Europe and survival at 5 years, and you can see that first, there are discrepancies across Europe in terms of probability of survival, 10 to 20% differences across Europe. Second, we made little progress over the last 10 years with the difficult-to-treat diseases. We need more innovation and innovative therapies to do better. And as I said, 2/3 of the survivors do have long-term effects. So based on that, the European community of pediatric hematology oncology with the parents define the strategic plan to increase cure rate in patients with poor prognosis malignancies, to increase quality of life, quality of cure in survivors, and to tackle these inequalities which are obvious at the moment in Europe. This was defined in a research program called ENCA in the 7th European Framework Program, showing that, yes, Europe invested in the field to help structure the way we will address these issues in the next years. This plan, the European Cancer Plan for Children and Adolescents, is available on the SIOP website. And there are three clear messages: cure more, cure better, and better understand. Because we cannot do more if we do not integrate research in all what we do for patients. An integration of care and research is the way we progressed over the last 50 years and the way we will continue to progress in the next years. We have 7 objectives. The first one is to introduce innovative therapies to treat patients where chemotherapy failed. The second is to use precision medicine, meaning to understand the biology of the tumor of a child, to orientate the best way possible the treatment we propose to the child, to increase knowledge on biology, because we won't make any progress if we don't understand better what are these tumors and how we can treat them. The fourth objective is equal access. Access to standard care, access to clinical research, access to innovation across Europe, tackle inequalities. The fifth one is teenagers and young adults, because they do have specificities. And this is extremely important, and this is an initiative that we run with our colleagues from the adult oncology world, where clearly the young adults and the teenagers need to be treated in the same environment, with the same treatment, with taking care of who they are and the specificities of their age. The sixth objective is obviously quality of survivorship. How can we give the patient information about his treatment? How can we give the patient recommendation on the follow-up? How can we prevent or reduce the likelihood of toxicity on the long term? And finally, the seventh objective is understanding the cause of pediatric cancers. One important question that pediatricians don't know how to answer is, why my child has cancer? 90% of the cases cannot be explained at the moment. And this is why this objective is extremely important, trying to understand the reason why children develop cancer in order to make early diagnosis, maybe prevent it in the future, but also improve the quality of our treatment. And we developed this program in partnership with the parents. In 2014, SIOP Europe and CCI Europe signed a memorandum of understanding defining that this plan will be developed together with the parents and the survivors. And ever since, we have been working in all our European projects with the parents, with the survivors, because this is the only way forward. And I will give you a few examples. So where are we? In terms of innovation, we build a strategy within the ITCC. ITCC is a network across Europe of 52 centers doing early clinical trials, the very, very early evaluation of new medicines in children. So we develop a strategy to try to improve, speed up the development of innovation for children and adolescents. The first step is to propose patients, parents, children, to be part of a clinical trial where we do a biopsy of the tumor and we look through molecular techniques on the molecular alteration characterizing this tumor, which is understanding better the tumor of the child at the time of relapse in order to help orientate the treatment we will propose. From this information, a molecular portrait for a child at relapse, we try to match the treatment we do have in clinical trials to the alteration we find in the tumor, in a way that we think it will improve the likelihood of efficacy of these treatments, and we will learn about how these drugs work or not for children and adolescents. In this setting, all patients entering the program do have a proposal to participate to a phase 1 or a phase 2 trial, whether they do have a target of a drug in their tumor or they don't. And the third step is very important, because from these data we generate, from the tumor of the patient, from the treatment, we merge all this big data just to have a large clinical biological database of all this information that will be used by researchers, basic and translational researchers, to understand better what are these malignancies, to find new alterations that could become druggable target of new and specific pediatric drugs. And ultimately, eventually, on this new knowledge, there will be development of specific pediatric drug for children. Here we are looking at drugs being developed in adults. Are they of interest, yes or no, for children? From these researches, coming from the tumor of the patient and the results of the trial, there will be new science, new knowledge, and we hope there will be new specific pediatric drugs, because we know that cancer in children is different from cancer in adults. There are common targets, but there are specificities. In adults, this is breast cancer, prostate cancer, colon cancer. I missed another one. Lung cancer, of course, sorry for that. In children, this is leukemia, brain tumors, lymphoma, and multiple other diseases. There are differences. There are common targets, and we do use common drugs at the moment, but we will find specific alteration that may turn into, new specific pediatric drugs. So this strategy is up and running. As an example, this is what's going on in France, will be open soon in Spain and in Italy. In this MAPIAX program, which is a clinical trials, we inform the parents and the patients. There's a biopsy, a molecular profiling, I will manage. A molecular profiling of the tumor, discussion with all people around the table, and proposal of a treatment into a phase 1 trial. This is up and running. We plan initially to include 300 children in 3 years. We started in January 2016. We recruited already 240 patients as April, and we will be up to 600. It is feasible to generate information from the tumor of a patient at relapse and try to orientate the treatment we propose in phase 1 and phase 2 with regard to the alteration we find. This is up and running in Europe. There are national programs, INFORM in Germany, MAPIAX in France, ITER in Netherlands, SMPED in the UK. We are enlarging the number of drugs we are proposing to patients that are at relapse entering the program, and we hope that by the end of 2018 we will have more than 1,000 exomes in relapse, which is a huge amount of data. And there will be researchers looking at this data to find new alteration, new pathway, understanding better the reason why cancer is occurring in children. Because the issue is not only having a molecular portrait, but having the drugs available. We decided to add a new trial to our portfolio. When a patient enters the program, he can participate to all these number of phase 1 trial of new drugs, which are up and running at the moment in ITCC. But to enlarge the number of drugs, the capacity to match alteration found in the tumor of the patient with trials, we set up an academic trial called eSMART, and we do have at the moment several treatments, several drugs, several treatment arms to increase the number of proposals we can make for this patient. And the eSMART trial is up and running at the moment. We have 5 new drugs from 3 companies. We will open new arms this year to increase further. So you see from this initiative, it's proposing access to innovative treatment, and this is research. Not all these drugs are effective. But this is a frame where access to innovation is feasible, including generating assets to understand better what are the diseases of the children. The second step is access to care, access to standard treatment. Very early, SciUp Europe defined the standard of care for children with cancer. It is not about how to treat a neuroblastoma. It's defining what is needed in a pediatric center to take care of children with leukemia and solid tumors. And from this, we explored how this is set up in Europe, and we identify inequalities across Europe, how the standard of care are being implemented. And in 2014, the European Commission launched a call for experiments, pilot research project to develop the concept of research and reference network. It was anticipating the implementation of the so-called cross-border healthcare directive. This directive is very important. It is saying a patient should be able to cross the border to get access to care in another country. And the Commission decided to set up a reference network, identifying where these centers of expertise are for a given diseases to facilitate the implementation of the cross-border healthcare. And the call was launched last year. There are now 26 European reference networks, and one of them is dedicated to pediatric cancer. What it means? It means that in pediatric cancer, in addition to what we are doing, we do have now the label of Europe for clearly defining in the concept of cross-border healthcare how a patient can get access to innovation, access to standard care, crossing border. And in addition, there is a joint action going at the moment. What is a joint action? These are the member states in Europe having a problem. They do have a problem, they launch a joint action, and they try to find people to solve this problem. And there is a problem about rare cancer in Europe. They are rare, expertise is scattered across Europe, patients don't easily identify where to go, and clearly improving care and research for patients with rare cancer is an important objective even for the member state. So in this joint action, we do run a work package on pediatric cancers, and the goals are very simple. First, to ensure access to standard treatment and to innovative therapies. Second, to develop optimal care and research for the young people with extremely rare cancers, because there are extremely rare cancer in children. All cancer in children are rare. But some of them, this is time for, this is not me. Time for tea? So, because some of these cancers are extremely rare, concerning very, very few patients. So we need to get and to define how best the expertise needed for these very few patients can be set up in Europe. And in addition, in joint action, we will continue to address the issue of survivors. What does it mean? It means that, if I can move forward with the slides, that would be great. That would be really great. Backward? No. Forward? No. Okay, we can continue on this one. You can do something, or maybe I should. Yes, this one is out. Let's go back to the keyboard. So we define the Access project. What does it mean? We do have, as you saw, a rather large number of proposals into phase 1 and phase 2 trials about new drugs. But what we want to do is increase accessibility of these innovations where the treatments are investigated. And this is this project run in the joint action in collaboration beside Europe, ITCC and CCI Europe. And we will look on how to implement a system where patients can be referred to a center where innovation is, including the cost of that, and be still treated in a continuation of care when we do participate to innovation. This is a very important project because we want, through this, in ITCC member states, but also in member states without ITCC center, define a way to facilitate access to innovation for children in the relapse setting. Oops. The fifth objective is addressing adolescents. I will not detail, but this is clearly a momentum at the moment which is up and running with adult oncologists and pediatric oncologists to figure out how best develop care for this specific population. And the survivorship initiative is a continuation with a very strong involvement in Sweden, and you obviously know Dr. Arts from Lund, who is dealing and leading the PanCare initiative, Lars. And we are coming from the concept of survivorship passport, which is proposing to a child or an adolescent finishing the treatment a summary of the treatment he received and recommendation about what are the potential risks and what should be done. And this survivorship passport will be implemented in the next 5 years, defining how these patients, no longer patients but survivors, should be followed. What is the model of care of this transition from the pediatric life to the adult life in terms of medicine, in order to be sure these patients are followed over the lifetime and best addressed in terms of potential sequelae and needed for follow-up. Finally, the objective 7, as I mentioned, is using the fact that at the moment, all genome sequencing is now something very easy to implement and more proposed. And from this information, we can really increase our knowledge about the predisposition to cancer. We have already 5 to 10% of children who do have a cancer in a well-known predisposition syndrome. But we do have story of patients where we did not find yet a gene. So this is really important because it will help us understand better what are the DNA alterations that can explain the development of cancer in order to develop more active treatments, and when possible, to follow this patient and prevent or diagnostic earlier the disease when it is occurring. To implement this plan, we also set up a cross-tumor platform and cross-tumor program and platform. I will not describe the 7, but just 2. The first one is Quartet. Quartet is a project to do quality assurance of radiotherapy each time a child needs to receive radiotherapy before he's receiving radiotherapy. It's a way to improve the quality of delivery of radiotherapy. It's a program that we are developing with the EORTC. It is funded by Foundation Krebskrant-Canov from Luxembourg, and it is up and running for 500,000 patients in 2 years from now to improve the quality online. Any patient before receiving radiotherapy can have, at the moment, through this system, quality check of the plan. And the second platform I wanted to share with you is Accelerate. What is Accelerate? It's a multi-stakeholder platform we created in 2013. What means multi-stakeholder? It means there are academia, physicians and researchers. There are people from industry, those having to develop medicine in children. There are parents, and there are people from regulatory bodies, the European Medicine Agency and the Pediatric Committee. The idea was getting all these patients in the same room and look at what was done over the last 5 years within the new regulation which is up and running in Europe. And it was a way to have everyone around the table. It's not really a habit to have all these people in the same room, discussing what was done and trying to find solutions how to improve the way drugs are developed for children and adolescents with cancer. From this initiative, Unite to Cure was created. Parents wanted really to raise awareness about the need to rapid development and access to innovative treatment for children and adolescents with cancer. I suggest you go to their website. They are extremely active, and we are working together in the way we implement this initiative and the way we discuss with the politicians to make things change. And all these people came up with 5 objectives, very simple. First, development of drugs and medicine in children should be driven by the science, and not this drug is for lung cancer in adults. There is no lung cancer in children, so there is no way the drug should be developed in children. If this drug has a mechanism of action which is relevant for lung cancer, but this mechanism of action is relevant as well for pediatric malignancies, this drug should be developed in children, even though lung cancer does not exist in children. Pediatric development should be based on mechanism of action, which means the biology of the tumor, rather than the adult indication. And this is important because the current regulation says if the disease does not occur in children, then the industry can get a waiver. The second objective is prioritize, because on one hand, we do not have access enough to innovative therapies to develop in children. On the other hand, there are many, many drugs developed in adults. At the moment, it is estimated there are 900 innovative drugs developed in oncology for adults. We cannot develop the 900. So we need to prioritize and identify what are the most likely to work and what are the ones that should be developed in children, based on the way they work, based on the needs in the patient, and the feasibility. Because we are dealing with a situation where there are very few patients, hopefully. But clearly, this is where all together we need to, at the global level, run this initiative with the best potential drugs in children. The third objective is reduce the delay. At the moment, all the new drugs that we are studying in children, we do have access late in the development in adults, and often the clinical trial, the first-in-child evaluation, starts after the drug has been approved for treatment in adults. We said this is not possible. We should have access very early. When the drug is entering the development in adults, we should look at yes or no, this is relevant for children. And if yes, anticipate and start early. We cannot lose time in developing the new drugs. The fourth objective is break the 18 years dogma. What does it mean? At the moment, an adolescent, 17-year-old and 6 months, cannot participate to a clinical trial running in adults because it is limited at 18 years. Which means that over the last years, adolescents with a metastatic melanoma could not participate to the clinical trials that have been rapidly developed in adults because they were younger than 18 years. This is not acceptable. When the disease is the same in adults and in adolescents, then the innovation, the clinical trials should be accessible at once for adolescents as well. And finally, we have been developing, trying to propose new incentives, because all this works if there are incentives for pharmaceutical companies to study the drugs in children. Because clearly, pediatric oncology is not a market. They cannot get return on investment. So there is a need for investment and incentive. And these incentives at the moment are working, but maybe there are better incentives and rewards that could even increase the capacity of pharmaceutical companies to move forward. But not only the pharmaceutical company, because clearly in this setting, charities, such as Barncancerfonden and others, are really important because they do fund programs, research, clinical research, early phase 1 and phase 2 trial, precision medicine trial, where clearly the funding is not coming from pharma. So all this initiative and momentum about innovation can be done with the strong support of charities at the moment. Finally, we move as well to the Parliament. From all this initiative with the parents, we went to the Parliament and we met with Elena Gentile from Italy, Françoise Grostet from France, and Glenys Wilmot from the UK. And we named them champions of childhood cancer. Why? Because they have been extremely committed. And they succeeded in putting a resolution in the Parliament that was voted on December the 15th, 2016, in a plenary session in Strasbourg, asking the Commission to make proposals on how to improve the way medicine are being developed for children and adolescents with cancer. This is important. The support of the politician, of the decision maker, the involvement of the Commission is extremely important to be sure that the legal environment is facilitating what we are doing, which is accelerating development of innovation for children with cancer. And I can even tell you that we have a very strong support of the Health Commissioner. I don't know if you know him, but this is Commissioner Andriukaitis, a very nice man from Vilnius. And he came to our meeting in where was it? It was in Amsterdam. No, where was it? It was in Amsterdam? It was in Amsterdam in January? Yes, we were in Amsterdam in January. Times fly very rapidly. And in his talk, he said, and he tweeted, children first, which means that we have a strong support at the Commission level, which is not the end of it, but it's good to have. So I would like at the end to thank very much all the parents, the patients who are participating to these programs. I would like to thank all the investigators and the team doing this, and I can tell you it's a lot of work to weekly deliver molecular portrait and enter patient in clinical trial. These are, at the moment, the funder of this program, national grant from, for example, the National Cancer Institute, the institution, and also charities from France and from Germany, and even Dell. You know Dell? You know the guys from the computer and so on? Well, they found this interesting, and they make a donation, and we have a big, massive storage system, because we cannot anticipate the storage needed for all these data that we are developing. And they gave us some storage, which is quite helpful just to move forward and store what we are doing. And of course, the pharmaceutical companies who are giving the drugs for our programs. And I would like to thank you for your intention, in addition to all the people, it's not me alone, all the people who developed this European plan, and not all people are on the slide, because the community is a community together. We are working together. We are working with the parents and the survivor. This is a left-hand side photo. And as you saw, we are building new concept of partnership with industry and with European Medicine Agency. Having said that, I would like to thank you very much for your attention.
Thank you for that great talk. I wonder if we have any questions from the audience. Olle?
Olle Björk heter jag. You're talking about recurrences, and you should see into the actual cancer cell, the biology of that cell. And that is a field for the new drugs. But what about using the new drug up front in the treatment?
Yes. This is a very important question. We are developing drugs at relapse because we need to define yes or no, is this drug active, and yes or no, it is safe, in order to introduce them in frontline therapy to treat patients who have high-risk diseases and likely not to respond to initial therapies. And we're already doing that in some diseases. For example, DIPG, which is the diffuse intrinsic pontine glioma, a very, very poor disease with very poor prognosis. We are introducing new drugs at diagnosis because we felt that in this disease, the overall survival is so low that we can introduce earlier, at the time of diagnosis, some new drugs. So this is the way we develop medicine. We propose them first for children with life-threatening, non-curable diseases. And when we do have evidence of activity, we move them up front. But in some disease, as DIPG, we take the initiative to introduce early the new drugs for these patients.
Another question here.
Hello. My name is Hans Engblom. The orphan drug designation regulation in Europe, is that good enough for pediatric cancer?
The regulation was launched in 2007 after 7 years of discussion. Since 2007, there is a clear change in the landscape. I've been in the field of drug development for, at least quite a long time. And there is a before 2007 and a after 2007. You saw the list of phase 1 trials that we do have at the moment in ITCC. I can tell you in 2003, when we launched ITCC, because we thought it was important to have a network dedicated to early phase trial, we had 1 trial. So from 2003 to 2013, we moved from 1 trial to more than 20 trials, which means that the landscape, the regulation changed the landscapes. But what we did, we identify what are the things that need to be improved. Because we are not yet where we thought we would be after 10 years. And what we are doing with the Commission is telling them, the regulation is good, don't kill it, but making it better. And these are the recommendations we make. In order really to improve the way, in this setting, that changes clearly what was happening. You know, when I started to do phase 1 trial, at that time I was almost begging pharmaceutical company to give a drug that we would run in phase 1. And they were telling me, come on, no, we cannot do that. You know, in children, if something happened, it could be bad for the medicine. I told them, no, it's not. We are doing research, and this is the way we go. Now it's not the case. Now they have to look at these drugs in children. But clearly we identify there is a way to improve. And the way to improve is accelerate. We don't have time to wait. And I showed you that we are really ready, the pediatric oncology community, in doing this precision medicine program, in doing this phase 1, in having these ITCC centers, in implementing a process to facilitate access to innovation. We are ready. So we need more medicine from them. So yes, the regulation changed, but needs to be significantly improved.
Yeah, I have a question also. Let the audience talk first, maybe. Yeah, okay. I was curious about this very ambitious...
I know this guy.
Okay, good. This very ambitious plan with these cross-border trials. Will this be something that the professionals will have sort of organized, or is it possible for the patients also to, is it transparent so that the patients can actually also see where the trials are held?
Absolutely. The Access project I mentioned, this is a project that we are running with physicians and parents. And the first meeting, which will be held in July, there will be from each country representative of the physician and representative of the parents. Second, how we address this? Information about what are the trials and where they are open should be available for the physician, but for the parents as well. Second, process of how a center will interact and work with an ITCC center should be established. Third, funding to make travel and accommodation feasible, because it's a cost which is not always taken by the sponsor, should be as well organized. So yes, this project is being implemented with the parents, because it is the only way it will work.
Mm-hmm. And this collaboration between all these different stakeholders, are there any other places internationally that could be a road model for us in Europe, or are we sort of ahead of everyone else? Or
I think we are paving the way.
Mm-hmm. Mm-hmm.
I've been invited in the US, and this is the momentum at the moment, but what we did in Accelerate, and I didn't talk to you about the Pediatric Strategy Forum, because we had already one meeting at the European Medicine Agency discussing with several companies, parents, physicians, experts, and regulators how we develop these specific drugs. So it's not only concept at the moment, but now it's a real life making some decision. So yes, we are, I think, pioneering something.
Mm-hmm. Mm-hmm. Interesting. Any questions from the audience? Yes, okay, there.
One more. I'm a layman in this area, but what about in the sort of adults? Epigenetics is getting more and more interesting. But what about epigenetics in children? How much epigenetics is there in a 1 or 2 year old person?
It is there, and we start only to understand where it is. For example, DIPG, brand new science in DIPG over the last 3 to 4 years. And the main hallmark is mutation of histones in DIPG. It's very, because all patients with DIPG do have a mutation of one histone or the other one. And it means that it's very early in the development of cancer. So we are just starting exploring the role of epigenetics, this capacity not only to look at what are the genes, but how genes are being regulated and the way they are expressed. It is a role important in the IPG, in pediatric malignancy. So we are at the beginning, and we do have already 2 drugs which are targeting epigenetics, which are in development in this program. And immunotherapy is the same. You know, immunotherapy in adults has been really changing the landscape in melanoma, in lung cancer, in bladder cancer, with all these new drugs. Unfortunately, we did have access only lately to these new drugs to start to understand if they would be of interest for patients in the pediatric population. But clearly, we are exploring immunotherapy. It seems that it will not be that easy, but then the knowledge from the basic scientists linked to what we are doing in the clinical field will help to understand how to make a tumor in a child hot enough to be responsive to immune cells. So this is new avenues beyond targeted agents that will be developed in the next years.
And with your collaboration, all of these stakeholders, I guess a lot of collaboration also has to be done with the adult oncologists, since we are talking now about molecular pathways, and much of this research is doing grown-up adult oncologists research.
Absolutely, and when the platform we are using to do the molecular profiling are not pediatric platform, they are platform, and they are used as well by adult oncologists for the patients. And we are collaborating. You know, the concept of 18-year DOMA that we want to break is a real message saying, stop making a barrier, work together, teenager and young adults, and address the disease rather than the age, which is clearly a way that collaboration with adult oncologists will continue to develop.
My name is Jens Collin. Thank you for a very clear and understandable lecture. That was very good. If you allow yourself to speculate a bit, where do you think we will be in 10 years ahead? What problems will be solved?
10 years from now, I think we will have more new drugs in the frontline setting, maybe not completely approved, but yet in the first treatment for those diseases that that are not cured at the moment. And there will be new drugs. At the moment, we have very few, mainly in the field of leukemias. And I guess in the next 10 years, we have really new treatments. I didn't give you some examples, but we are already seeing some patients with a very rare tumor and a molecular alteration that benefit from targeted agents. So in 10 years from now, there will be new drugs. Maybe we will treat completely differently some of the disease. Maybe leukemias in 10 years from now will not receive, maybe not 10 years, 20, no more chemotherapy, because it will be only a treatment using immunotherapy. So in 10 years from now, I see some changes in terms of new medicine for the treatment of children, and for sure, looking at the tumor, looking at how the tumor is evolving under treatment. I didn't tell you, but now we are doing liquid biopsy, because we cannot repeat biopsy of the tumor in a child. We are looking liquid biopsy, which is draw a blood sample, and we find the interaction in the tumor, which is a way to follow over time what's happening to the tumor. Because we know that those tumors are very keen to evaluate. They are keen to become resistant to the treatment we give, even to the CAR T cell, which is really at the moment an effective treatment in acute lymphocytic leukemia. There are resistance to CAR T cells. So learning and clearly understanding how the tumor in a child is evolving will be in 10 years from now in the daily practice in order to orientate the best treatment for each child.
No more questions? Then I think we have thank you once again for a great presentation, and we have a small gift here. This is Trygve. So it's a Trygve, it's a Swedish name.
Trygve. Hi, Trygve.
And it means safe and taken care of.
Thank you.
And a diploma.
Thank you very much.
Thank you.
Thank you.
So the next speaker is Professor Martha Grotenhuis from the Princess Maxima Center for Pediatric Oncology in Utrecht, the Netherlands. Martha works on psychosocial functioning and quality of life for children with cancer and their families. And the title of her talk is E-Health Intervention, Supporting the Needs of Children with Cancer, Their Siblings and Parents. Welcome.
Thank you. Yes. So thank you for inviting me here, both to the NOVO who invited me and now today again. And I'm happy to share with you, another area of research and care, which is very important, psychosocial outcomes, psychosocial care, and the things we could do about this during all the different treatment phases. And as just said, I'm coming from the Netherlands, and in the Netherlands we are also focusing, as we are talking here, about improving survival. And a way to improve survival is to have the different centers together in one center, centralization of care, and this will not be new to you. But in the Netherlands we have 7 different centers spread all over the country. And as you know, the Netherlands is not very big. It's not as stretched as the Nordic countries here. And we have been working on the Princess Maxima Center in the middle of the Netherlands in Utrecht. And it's unique. And it has the same reason why we are here all together, to improve the survival of children with cancer by centralization of care. And this centralization has been put together by both the parent organization and the different centers in the Netherlands, which is important because the parents have been thinking about this centralization for years already. And this is how it will look like. It's being built at the moment, and it will open in May 2018. At this very moment already children with solid tumors, particular solid tumors, are already treated centralized in Utrecht. And in May 2018, all 500 children will be coming to this center. And it's in 2 ways it's unique. And that's also one of the reasons why I was very happy to join the center. And it's unique by its focus on survival, but it's also unique on its focus on quality of survival. And they have said, okay, our mission is improvement of survival, but also the improvement of quality of life and quality of survival. And in that context, we have a program which is called the Developmental Oriented Care. And the idea is that the focus in the care and also in research, but also in the environment of the hospital should be towards stimulating all the different domains of quality of life, which encompass or incorporate both physical quality of life, but also emotional, social, and cognitive development. And these different domains of quality of life should be supported during all the different treatment trajectories, but also during survivorship. And we should have an eye for this. We should be looking for these outcomes. And if you want to stimulate those domains of quality of life, you need to communicate about this. You have to pay attention to it. The care has to be family integrated. There should be a focus on both children, but also parents, but also siblings, and in my opinion, even grandparents. And in such an integrated, holistic way of providing care in a hospital, everything is also dedicated to decreasing medical traumatic stress. And I will pay attention to what this is in a little bit more detail in the next few minutes. I'm a researcher, I'm a psychologist, trained psychologist, but I do full-time research. And in research we all, both me as a psychologist, but also physicians, we are all trying to hear all the voices, hear all the stories, and try to find some mean thing through all this, to find what's happening and to find answers. And that does not necessarily mean that every story which is represented by every family can be caught, because there are many different stories. And so I would like to stress that even though we try to hear all the voices by using questionnaires and using interviews, there are still, everybody has their own story. And what I will present, I will share with you what we know from research for children and parents. Might not be everyone's particular story, and might think, well, this is not me, but we know by all the stories that this is what we in generally see. And what I would like to share with you, and also the ones who are watching with the web, is this model. And in this model, we try to distinguish what we are looking at when we are doing research. Because we are looking at a child in a medical context, a child with a disease, a child with cancer. And even though we talk about cancer, these are many different diagnoses which we all know. It might be many different stories also. And then child is always part of a family. And when we are looking in the context of psychosocial functioning or psychosocial outcomes, we are looking at outcomes not only for the child, which you see on the right side of the slide here, but also for family. And there are many different outcomes. You can talk about psychological outcomes or quality of life. You can talk about outcomes in the context of age. For example, when you talk about school, you talk about school for younger children who are going to kindergarten. But if you talk about school when you're older, it's about education, your employment. Those are different ways of looking at outcomes. And so you can see many different, this is just a short overview of what you could study. But we also look at outcomes in a medical context. So the things we do in a medical setting, we study them as well. Are you satisfied with the care you get? The knowledge, a lot of information is provided. The families have more knowledge when they have education. But these columns are important to distinguish. We know when we do research, we try to find out what predicts a particular outcome. And we are talking about medical prediction models, so what kind of genetics or molecules or treatments are related to survival. But we are looking at predictors who are related to the outcomes. We study psychosocial outcomes. And these predictors might be some things you bring with yourself. When you're coming to the hospital, a family, it might be a family from many different countries, many places. Families might have many children or not so many children. There might have been already things have happened in a family, maybe even cancer or other life events. Those are all things which might be considered as medical or social demographic determinants. And obviously there's also the disease with many different characteristics we study. The diagnosis or the the duration of treatment, the kind of treatment, chemotherapy, what kind of chemotherapy, all those determinants are important in explaining outcomes. But in the middle you see many different things. And those are the things, the way children adapt, or how families adapt to the situation, and we call them mediating factors. And I generally try to explain it as the things families do to cope with the situation, to cope with the medical treatment, everything they go through. And so we also know that these characteristics are very important in explaining psychosocial outcomes, because it's the way you cope, the way you are able to see the situation. And it's also what we as healthcare providers do in the medical setting. So that's here in the middle, the way we provide information, the way we talk, the way we provide the diagnosis, the disclosure, and everything what's happening through all these different phases. So that's in the middle. And we also know that if we want to provide interventions to improve quality of life and improve psychosocial functioning and lessen the difficulties, we need to do things which are related to those kind of predictors. So the intervention should be focused at cognitions. That's what we call, in psychology, for example, cognitive behavior therapy is related to changing cognitions, the way you think, or increasing self-esteem, how to cope with the disease, to cope with everything I do. And here we see interventions in the medical context which relate to communication skills. They relate to paying attention, to discussing quality of life during clinical practice. And I will talk with you about things we have developed, things are interventions, to improve quality of life. But I would first like to share a little reflection with you. Maybe you already heard me talking about outcomes, and much research is focused on psychopathology, which means a patient or a person scoring high on a particular instrument, reflecting impairment, having a clinical score. And the question is, if you do not have a high clinical score, does it mean you don't have a problem? And when do we consider something a problem? And that is really important to realize when you look at the findings from psychosocial quality of life outcomes, that there is many discussion about how do you define a problem? When is something considered a problem which we should relate to? And over the years there has been a lot of discussion about these outcomes, and also a reflection on maybe those psychopathology outcomes, disorders like DSM disorders, anxiety, depression, are not the things we should study. We should look at different outcomes, which are more related to the things children with cancer go through and what kind of problems parents encounter. So there has been a huge change in the measurement of using questionnaires from psychiatry, going to disease-specific questionnaires, or also quality of life, but more sensitive to the outcomes of children and parents, what their experiences, so they're really acknowledging the things children and parents go through. I would like to summarize a little bit about what we know from outcomes and the predictors, which the model I shared with you. And this is, if you look at the research, resilience is a rule rather than the exception. And if we look at studies, psychopathology is not what we find, which is a good and hopeful message. And I think that's important to share. And we see children have difficulties, they have elevated risk for psychosocial distress, but it's not clinical psychopathology. And I always say, in addition to this, this does not necessarily mean there's not a problem. It means there are disease-specific problems and children encounter challenges throughout the trajectories which differ over time, and we should be very attentive to that. We have also been doing studies on siblings, and we know siblings encounter difficulties during treatment and thereafter, and we should be sensitive to them as well. If you look at the literature and you look at findings from parents, we generally find more difficulties for parents. Everything changes forever when your child is diagnosed, and the security is never back again. And that's being reflected in findings in research, like more symptoms of burnout, tension, work and payment related issues. Families, mothers and fathers have many different encounter different difficulties. And what is also very important to stress is that there's a relation between parental stress and children's stress. So we know those parents who suffer more children also have more difficulties. So if you look at interventions, when you want to help children, you should also intervene with the parents. A little bit more about those risk and protective factors. The factors we would like to find out: who are at risk, who should we target? Well, we know, if you look at the population, we know children with brain tumors have more difficulties, children with comorbidities or late effects. We know, if you look at the socio-demographic factors, the left side of the model, we know that lower socioeconomic situation, less resources, more difficulties, pre-morbid functioning are important. If you look at the middle of the model, we know that social support is a very important mediating factor. Social support, having a good environment, people around you, is protective. And so in general, we do find that non-medical factors such as self-esteem and social support are very important predictors of psychosocial outcomes. And I'd like to share this slide with you to be aware of those different phases of treatment, because we are easily talking about treatment phase and everything what's going on and the child during treatment, but there are many children who survive, fortunately, and they have a long life ahead, and they end treatment, come in their follow-up period, and they will be survivors when they are, which is defined as 5 years after diagnosis, and they will also go to another phase as an adult, 18 years of age, going to the late effects clinic for adults. And all these different phases have their different challenges. So if I've been talking about the things we know, what's going on, but we want to do something about it. So what are the things we can conclude based on these findings? What can we do to lessen the psychosocial burden of both children and parents? We should screen and monitor. We should look at those. We should look who are at risk. When do we need to intervene? And I think I have been in this field of research more than 20 years now, and I think all discussions of articles are ending with the conclusion: we do see difficulties in children and parents, and we need to monitor and screen them. And still, not monitoring and screening is not the basic care which is implemented, and we really should be attentive to that. If you think back about my reflection on when is something considered a problem, we know psychopathology is not a rule, so interventions should be focused on empowerment. They should be devoted to creating competence in children, rather than reducing psychopathology, because that's not the main outcome. And this means that we should have preventative interventions. We all know the worth, we all know how important child life specialists are in the clinic, who are helping children to know about the medical procedures which are happening. Those are all very preventative actions in clinic, which help children relate to the situation. So preventative interventions are very important. we need to focus not only on the patient but on the family. And if we want to reach many children and families, we could use the internet, because obviously that bridges the distance to the hospital. I will share with you 3 examples of interventions we have developed, and they are related to what I just said. It's important to pay attention and provide information in the clinic. It's important to monitor, and it's important to empower children and parents as well as siblings. But I first want to pay a little bit more attention to medical traumatic stress. And yesterday, when I talked here with the NOVO meeting, I asked the audience, do you know the definition? Do you know about this, medical traumatic stress? And no one raised their hand. And I think that's important to acknowledge that this is one of the basic things what all families encounter. There is a lot of stress, and you all know it, obviously, but it's important to use this definition, that all these medical procedures, the pain, injury, invasive and frightening treatment experiences can result in a medical traumatic stress, and if it's very hard for children, might even be a disorder, because it's a continuum. And you know about post-traumatic stress disorder, it's something we are familiar with, but those can be an outcome as well in case children react with a lot of medical traumatic stress. So many of the things we do in clinic is to decrease this medical traumatic stress, and we all do a lot of things in the clinic, but it's never enough. It's not only something for pediatric oncology, it's also related to other illnesses, pediatric illnesses. It's children with burns or children with other traumatic disease experiences. It's important to know something about the reactions to a traumatic event. And this will also be familiar to you. Anyone who has been experiencing something stressful or traumatic, either whether it's a disease or something else, losing someone, having an accident, divorce in the family, all those result in increase of stress. And many people after a stressful reaction are able to recuperate, and the stress goes down. This is what we call resilience, being able to recuperate after a stressful situation. Some people are not able to do so. So they have continuous stress reactions, which even may escalate or become chronic, but hopefully will recover either by itself or after interventions provided. This increase of arousal is obviously a normal reaction to an abnormal situation, because diagnosis of cancer is an abnormal situation. In the USA, there is a platform, it's called the Healthcare Toolbox. I apologize for the slides because of the web-based projection, they changed a little, but I think you can still see the website. And they pay attention to medical traumatic stress with very many good suggestions and interventions, but they use the DEF model. And I want to stress this because in medical care, ABC, airway, breathing, and circulation is very dominant. We look at those. But we should always also look at the distress, emotional support, and family. This is also what counts. And if we pay attention to this, we assess it, we ask about fears and worries. When we look at what patients and family need, and when we consider their distress, that might be preventative in preventing traumatic stress later on. So we have translated this material in the Netherlands to a website which provides information to parents and children and also to healthcare providers. And there's information available, and we trained the ICU members in our hospital in Amsterdam where I also work. And this is an example of how taking DEF into consideration in a clinic could be used. I will talk a little bit more about monitoring and screening and why this is so important and why I think this could be, I think if we are focusing on increasing quality of life of children with cancer for the next decade, I think monitoring and screening should be one of the things every clinic should have available. And we have developed something which we use and could be an example, but it is important to pay attention to quality of life and to pay attention to psychosocial problems in the clinic. And why is this? Why is it so important to monitor and screen? It is because early recognition of psychosocial problems leads to less severe, less disruptive behavior, better adherence to treatment, greater trust with the treating team, and less stress on the staff. So if this is done on a systematic way, it not only leads to less difficulties for the children and the parents, but also it's good for the staff itself. Maybe you know about this. In America, there has been a group who have been developing the psychosocial standards of for children with cancer. It has been published. There are 15 different standards which describe the minimum of psychosocial care which should be available in every clinic to follow children, parents, and siblings. And it's called the Psychosocial Standards of Care. It's published in Pediatric Blood and Cancer. And one of these standards is this one, which also stresses again systematic assessment of psychosocial healthcare needs of children and parents. And I like to put this under your attention because the psychosocial standards are important on an international level as well. But also this Declaration of Dublin, it's provided by the Childhood Cancer International Group, and this group has been mentioned also in the previous talk. This is a declaration of the survivors, what they want in care for survivorship internationally in the future. And you can look this up on the internet. But I would like to stress the comprehensive care part mentioned in their declaration. We are talking about together a lot on this conference. Together is often together with other sites or it's other countries. But I would like to stress that together is also together the medical team and the psychosocial team. As a psychosocial researchers, we are not as far internationally based as the physicians are. And we can only get further when we work together as researchers in this field. And so my hope for the future will be that together is also more together with the psychosocial teams. I'm stressing this monitoring and screening. And this can be done by using PROS. And PROS might be a word which you have heard or which you use. It's a very popular buzzword, PROS and PREMS. And PROS mean patient-reported outcomes. And it means a direct report from a patient without the interruption of a third person. So it's something that's self-reported. And it can either be quality of life or symptoms or, well, all different kind of things which we ask the patient to report about. And these PROS are more and more often used to evaluate care or to systematically assess value-based healthcare. It's something you also will hear. And we have used these PROS in clinical practice. And that is a particular field. PROS in clinical practice means you assess. You use questionnaires, but you do not only use questionnaires just to have the answers on the questionnaire and use it for research, but no, we want to see what you are reporting, we want to know what's going on. So we ask children to fill in questionnaires at home on a laptop. And here you see a pediatrician who's able to go into this website, open the answers which the child has given, and talk with the child about the answers on this questionnaire. And this is a way of monitoring quality of life. So this is PROS in clinical practice. This is what it looks in detail. On the left side, you see a questionnaire. These are all items on a questionnaire. And with the colors, you can see what a child has answered. This is in Dutch, but it's not relevant because the colors explain everything easily. If it's green, there's no problem. If it's orange, there's some problem reported. And if it's red, the child reports he often has a problem on a particular item. These are the scale scores, so the mean scores on a particular, on these items. For example, the blue items are here the mean scores on all these items. And these are the different dots are different assessments. So if you have a child filling in this questionnaire over time more often, you can see what's going on. And you can talk, you can see where a problem is. And for example, here you see at physical items, those were low. And so the physician can talk and see what's going on. And do the things he would otherwise also have suggested, but maybe could have missed if he would not have been asking all the questions. I've been in this research for quite a long time. And I started using PROS in clinical practice just using a laptop. So it was, we printed it, the profile, and we brought it to the pediatric oncologist and they could look at it. This was obviously not very handy. So we made a website and we first had a study using the website and providing the answers to the pediatrician. And when we had effectiveness, we found that psychosocial problems were more often discussed and detected and were earlier detected than normal. We decided to implement this website, so we had what we called Click 2.0. It's much more, things were possible, many different questionnaires in the portal. And I was also interested whether it was possible to use these kind of questionnaires during treatment of children with cancer. So we had another study which was about implementation. Implementation of an intervention is quite something else than doing research, to put it into the real world. And now at this very moment, I'm working in the Utrecht, as I explained, and we have decided to use this Click portal as the main portal for all things which we do with questionnaires online. So both for research, but also in care, using the PROS in clinical practice. These are the results of using such a portal, using PROS in clinical practice in a summary. It increased discussion about psychosocial functioning, better detection, increased satisfaction, and it didn't take longer time. And that's important because many pediatric oncologists say to me, I like this, but it takes too much time. Sorry, I can't do that. But we proved by taping all the consultations and looking at it that it didn't take more time. But it was even shorter, actually. And they were able to discuss more in detail those topics who needed more attention. And this is to show you how different, these are the users of such a portal. It's not only the pediatric oncologist, but you can use it in a team, the psychosocial team, as well as including psychologists and social work. They can all use, depending on how they want to use it in a trajectory, use those kind of PROS in clinical practice. I talked about family, of course, and we didn't have enough questionnaires for parents available. So we developed a new questionnaire, and it's called the Distress Thermometer for Parents, a DTP. And this is a questionnaire to measure stress which parents encounter having a child with an illness. It has a thermometer from 0 to 10, but also many different questionnaires. And it's in the adult oncology world, there's one questionnaire which is being used in many different studies and also in clinical care, which is called the Distress Thermometer. And it looks much like that questionnaire. We were also interested to know more about families at risk. I talked with you about the model, remember the 3x3 from the start. And we know things about risk and protective factors. And in the United States, the research group of NKSEC, they developed the PET questionnaire, which is a psychosocial assessment tool. And this questionnaire takes into account those risk and protective factors I just shared with you. And it includes questions about family structure and resources, social support, family problems, child problems, stress of the parents, sibling problems, and illness cognitions. And these all relate to the risk of experiencing psychosocial problems later during the trajectory. So this questionnaire could serve as a screener of risk in a family. And this risk of having psychosocial problems, so the risk and protective factors, also relate to this model. And this model is called the Pediatric Psychosocial Preventative Health Model. And this model is distinguishing different families. We know from research, as I shared with you, that many families are resilient. People are able to cope with difficult things in their life. And it's not necessarily so they can all do this by themselves. They need support from us, and they need help and a lot of work, but they are able to recuperate themselves. These are universal, what we call universal risk. Not that much risk, and this is the majority of the group. Children and families are distressed, but they are resilient. And this is a targeted group. There's acute and elevated distress, and there are risk factors in the family we should know about. And there's a smaller group who have many risk factors. And this PET questionnaire I just shared is a questionnaire which can help us in the clinical practice to see and validate our feeling of a family. Is this a risk family? And we can provide additional care to it. For example, if we know a particular family is at high risk of experiencing psychosocial problems, we could say from the start, okay, we will have more psychosocial care, for example, a psychologist and social worker together. I can imagine that you think, okay, this is really nice. You have this web portal, and you can have these questionnaires and put them in there and use it in a psychosocial together in a holistic way. I can only say that if you don't have something like this, still you always have to take these domains, these different domains into account, either using paper pencil questionnaires or either doing this in your clinical practice and thinking, okay, I have to pay attention to all these domains. It's not only about the physical thing, it's about everything. And asking how school is not enough. It's important to ask, are you able to go to school? Do you miss school? If you miss school, why? Are you able to concentrate? Do you need help? And you need to share this with the parents, what's going on. Just asking how school is not enough. So going from the monitoring and the screening, sorry, I go to, oh, I need some water, I think. I go to the empowerment program. We have been dancing and singing with the Novo yesterday, so you can hear it. Okay, the last part of the presentation is about this empowerment program. And in Dutch it's called op koers, which is very Dutch. It means something like on track in English. And this relates again to the things I started with. We know that children face challenges and stress. And these are things all children are encountering. It's not either you have leukemia or a solid tumor. Children face frequent hospital visits, medical procedures. It results in school absenteeism, and they have restrictions in social and sportive activity. This is related to stress, and stress can result in internalizing or externalizing problems or quality of life problems. And coping, the way they cope with it, if they're able to be facing this, if we are able to help them coping with these outcomes, this might be a preventative intervention. So we developed a course program which is called On Track, like I said, and it's to prevent or to reduce psychosocial problems by teaching active coping skills using CBT techniques. And it's a group course, so children coming together, and we started with face-to-face groups, so groups together in the hospital. And we have been developing a program in our hospital in Amsterdam, also including children with other pediatric diseases. And these can be easily mixed as well, because children with diabetes or inflammatory bowel disease or even rare diseases encounter all these challenges which are very comparable. We made courses for younger children going to primary school and secondary school. And these are the learning goals of this kind of empowerment programs. And we know that if children come together, this is really helpful. There's been many research that coming together and getting to know others who face the same is really helpful for children who are ill and are having cancer. And you know all about that with camps, for example. It's helpful for children. These are the goals: information seeking, giving information about your illness, being able to tell and share your story. What do I want to share about my illness when people are asking me something? Do I want to disclose everything, or I want to have a particular story? So it's important children relate to this. They learn relaxation techniques. They learn to enhance social competence, and in case of lifestyle advices, increase adherence techniques, but most of all, positive thinking. What do I do when I'm having negative thoughts? How can I relate to them? This is a long story also. This has taken me many years to come and develop all these kind of courses. Actually, we started with group courses for siblings, and we still provide these courses for them. And thereafter, we have been also studying the effectiveness of these kind of courses, and we were able to show for children with a chronic illness, but this will not be very different for children with cancer, that these kind of courses in the hospital are effective. And thereafter we thought, well, it's not possible for everybody to come to the hospital, and we should go online, like many people have been developing e-mental health interventions. So we started an online course, and we are now also doing research to study the effectiveness of online courses, which are also available for parents. And this is what it looks like. These are psychologists. They log into the system. The whole course is built online. It's a group course online, so it's important to remember this. Many things online are on an individual basis. This is a group course. So children, at the same time, log into the web portal, and together they chat, so everybody's able to respond, and we as the course leaders are able to provide them information, movies, exercises, to have these learning goals into practice. We have now in the Maxima Center, we have different groups available and going on. And we are also doing research now to find out whether young adults would also benefit and like this kind of group courses. I would like to also share, as the end of this presentation, some reflection on all these kind of interventions and websites. It's important to keep in mind, we are all trying to put new websites into practice and new initiatives and products, and every country, every site is developing different things. Do children and parents and siblings know to find all these initiatives? And if you look at children with cancer, but also children with other pediatric illnesses, there are many different initiatives in every country, and sometimes it's too much. But there's another worry. I've developed many things in research, but the question is, when we have evidence and we know it's working and people like it, who will provide it? Will the unit put money into it, because it's taking money to keep this into the air. That's what we say in Dutch. And will the pediatric oncologists give attention to this? And that's something we should pay attention to. So I'd like to end, take-home message. There's no doubt that childhood cancer is stressful and burdensome, and that even though we find not that much psychopathology, there's a lot of challenges through all the phases, and comprehensive care is necessary to prevent problems, and we can only increase the quality of life of children if we have comprehensive care and we have care together, medical and psychosocially. And monitoring and screening should be part of any clinic, and I've said that already before. So I'd like to thank you for your attention, and obviously I also thank all my colleagues who have been working with me in these programs, and all the children and parents who participated. Thank you.
Thank you, Martha, for that fantastic presentation. Do we have any questions from the audience? Mats?
Mats Heiman, I'm a pediatric oncologist here in Stockholm. I'm interested in the CLICK portal because it's something we have tried to build up in some ways. But for how long have you been doing this? This is creating a very large database in the end. How do you treat this growing? This is like a treasure trove in some ways. Are you consenting people to use this for research as well, or are you? What's your plan for how to use the data? I mean, I can see the clinical use in the consultation room. But this must be fantastic also for other purposes.
Yeah, it's many questions in one question. But this portal is made for clinical care. But every family who is filling in questionnaires is asked informed consent. So we ask them whether we are allowed to use the data for research. So you are absolutely right. If you use this, you have like a data bank underneath it. Every questionnaire which is filled in goes into this data bank. At this, our plans for the future are for the Princess Maxima to use this web portal as a combination for care and getting all these research data, but we need to put a lot of effort into filling this database and not having too much missing data, because otherwise, if children are not filling in the questionnaires, we will have like a scattered data plot. So there will be put time and effort into it to combine these two aims of care and research, which is a challenge. Because it's not always obvious for families, especially from the start, what we really ask them. Because we ask them two different things. We ask them to fill in this questionnaire to be used for this monitoring fact, but we also, if the database is really full and really rich, we can answer many research questions. And we also know from informed consent research that it takes time for families to really understand everything involved with informed consent and everything what we are doing with all the data we collect. So it will take some time to really get this full. Other questions?
One very short question.
I was just wondering if you could expand a little bit on one of the answers to that question in terms of what kind of success you have with the children in filling in these questionnaires to use them in the clinic, because I can see the advantage of it.
Yeah, that's a good question as well. And I didn't pay much attention in this talk about our implementation research. And those, the children and families do fill in the questionnaire. If you think about this pros in clinical practice, 3 things are important. Registration of a family on the CLICK portal. The second one is they fill in the questionnaire. And the third one is the pediatric oncologist or the nurse talking about these outcomes. And if we look at this, we see that the registration, that's possible. We go to the families, when we explain, they go to the website, they register. Then they get an email at the particular time point when we think it's appropriate to ask them to fill in the questionnaire, which goes by email, and if they don't fill it in, we have a team which will call them. Then we are missing some of the families. They're not able to fill it in. And then we are missing more families because not all the pediatric oncologists are talking about it. So these 3 steps, I think we are in an increasing curve in the Princess Maxima. It's becoming more and more part of the clinical process. A danger of a new hospital with all the challenges of centralization, all people coming together, is that they don't have time for new initiatives, new ways of working. So I know it will take time, but in the meantime we're making progress because the mission in a hospital is attention for quality of life, and we know that this will help to put it into practice. So it's still a way to go. Yeah.
Thank you very much. We have to take a short break, I think, for 15 minutes, and you will have a Trygve here also for you.
Yes, thank you.
Thank you once again. So we will have a very short coffee break now, so please be seated again here at the latest 3:45. Thank you. Oh. Hörs fortfarande här. Yeah. Yeah, good idea.
Pratade sist här, hon är inte med i paneldebatten.
Hey Cortana, what's the meaning of life?
We all shine on, my friend.
How are we supposed to shine on when we're so busy just trying to get stuff done?
Artificial intelligence can help. For example, I can give reminders and updates so you can focus more on what's important to you.
Your AI, Cortana?
Yes, people are already across all kinds of devices.
It seems like we've dreamed of this forever. Why now?
A combination of advances in data, algorithms, and computing power.
Okay, but
Okay. Hello, yes. So, it's time to continue. Are the coffee drinkers inside, Hans? Yeah. Okay, so welcome back, and welcome back also the internet viewers. We will now continue with the next speaker, that is Professor Kjeld Schmigelov from the Rigshospitalet in Copenhagen in Denmark. So Kjeld research focus on personalized medicine and the role of patients' own genome in cancer development and the risk of developing acute and long-term side effects from treatment. And the title of his presentation is "Who am I treating when I treat a patient?" Welcome.
Tack. Hello. So I'll just move this a tiny bit. And then I think I activate it here.
Let's see if it's...
Oh, just move forward.
Yes,
okay.
Yes.
Sometimes life is just too simple.
Yeah.
So the focus in general over the last 30, 40 years has been on the cancer itself, as if it was an infection, something alien inhabiting our body, the body of our patient. And now, and more recently, we have had more and more focus on the patient as an entity, not just in the psychosocial context, but in the biological context. So if we look back on the development of cure rates over the last 75 years, when we have had cancer registration in the Nordic countries, the cure rate has leapt from just around 20% to now almost 85%. And everybody would agree that this is a major success for healthcare. The question is really, does that reflect the true picture? So there's a caveat to this. So we can compare two time periods, a previous one and a more current one, and say, well, cure rates have gone up. But it has gone up with a price. It's gone up because we have intensified therapy, and thus we have also increased the risk of serious toxicities. And some would say, well, that is a price we need to pay to cure more patients. However, we already cured 50% of the patients. They have not benefited in any way from the more intensified therapy. And we still fail, sometimes completely, or sometimes just by the first-line therapy, and we have to treat again, for 25% of the patients. There are more toxicity, but we were not curing more patients for our treatment strategy. It's only the smaller proportion of the patients who are between these two curves that truly benefited. As we rises the cure rate curves, the fraction of patients that will be benefited from the general intensification gets smaller and smaller. And if we look at the outcome measurements, you could say that things like treatment resistance has certainly something to do with leukemia, with the brain tumors, with the solid tumors, but the host plays a role both for the cancer response, for the toxic death, and for the secondary cancers. And we can change the picture and say, let's look at healthcare in general. What do children die of if we compare any causes? And back in the 60s, approximately 10% of patients that did die in the age group 1 to 15 years did die of cancer. But more recently, that fraction has increased to 20%. So how come that we are curing more and more children with cancer and still the fraction of children dying seems to be increasing? Well, that is because we've had far more successes in curing the other patients. Patients that died from malformations, patients that died from infections, patients that die, or individuals that died from accidents. So you could say that today, even though the cure rate is so good, the health challenge of childhood cancer is even more profound than it was proportional-wise 50 years ago. But we don't always have to pay that price. And you could say that most of the improvements in cure rates has been obtained without an excessive toxic death rate. These are data from the US. The Nordic group will be able to provide the same. So we take patients who have been surviving for the first 5 years. So that is a requirement to go into that study. You need to be alive 5 years after diagnosis. And then we look upon what patient dies from. So back in the early area, the 70s, approximately 20% will still have a likelihood of dying within the subsequent 30 to 35 years. And when we go through the time arrows, that figure has dropped and dropped. And it is primarily dropped because fewer and fewer patients die from the cancer, whereas risk of death from toxicities has been almost stable. Okay, our healthcare system is being better even at treating complications. So there is a way forward. But the way forward just by increasing therapy for patients is not sufficiently good. So how do we as oncologists measure success? And it's clear that parents only measure success by one single parameter. Did my child survive? There may be toxicities that are burdensome, but did my child survive? But when we, in pediatric oncology, shall evaluate the efficacy of a protocol, there are 5 parameters we address. Do they die during induction therapy, that is to control the disease? Do they have a resistant cancer? Do they die even though the disease is controlled? Do they get a relapse of the cancer, or do they get a secondary cancer? That was fair many years back, but now we cure many patients with secondary cancer or relapses. Some would evaluate protocols instead of what we call event-free survival, saying just looking at survival may be the most important parameter. How many patients do we cure? And as we've talked about today, approximately 85%. But for those patients that are cured, that's not a sufficient measurement. We need in some way to implement another term, quality survival. And although many people talk about quality survival, we're probably not talking the same language. So this is really about a number of patients having been burdened to such an extent, even though they are cured for the cancer, they cannot live a life that they wanted to pursue. And this raises a question for us as clinicians and researchers. If we monitor acute toxicity as therapy is ongoing, can we then predict the long-term effects? The second thing is, do physicians at all capture and register all these toxicities because so much things are happening during the therapy? And even if we as physicians register all the toxicities, how well does that correlate to the patient's own perception of his life, as Martha addressed before? In Europe, among the politicians, there's a lot of talk about how happy is Europe. And of course, it's nice to know how happy Europe is, even though some are leaving us. The way they measure this are based on 3 parameters. A cognitive parameter called life satisfaction. So life satisfaction is a very personal issue. You can ask people how satisfied are you from a scale from 0 to 100. The second issue is how often do you have positive feelings, or how frequently do you don't have any negative feelings? And that's another measurement of the happiness of your life. And the last thing is something called eudaimonics, which is really something about the meaning of life. Not the meaning of life in a religious way or an evolutionary way. It's just that my life in some way makes sense. And if you've had a child that have had cancer, that child grows up very burdened by the therapy. Sometimes that trajectory from disease through cure to these late effects may not be meaningful. When we do that on a global scale throughout Europe, the most important thing for patients or normal individuals' life satisfaction is their health status. We can do a lot about the social and economical and educational profile of individuals, but the health status is the most important parameter to predict life satisfaction. And that is important to know when we do all this kind of research to improve these patients' life. This is the basic that will form their life satisfaction for the future. the overarching question, can we reach 100% cure rates? The question is, of course, very nice. And it may not be unrealistic, but there's no one solution. I think all cancer foundations, they want to put their money in the pot where the solution is. And there's no one solution to this. The only reason we reached 85% cure rates today is not any single thing we've done. It's thousands of research projects. It's basic research, translational research, psychosocial research, all kind of things that brought it forward. But of course, there are some key issues we need to address as we move forward. And of course, can cancers be prevented? Can we do genetic modification even before life is formed to ensure that parents don't get children with cancer? And may be realistic someday. But if we cannot prevent cancer, how can we improve the cure? And mapping the host genome is probably one of the most important parameters. We need better precision medicine, including molecular targeted medicine, as Jill pointed out. We need to engage the patient's immune system because we are combating cancer every single day in your body. Every one of you, at every single second, get novel cells, and they are combated by your immune system. One of the reasons why older people get cancer, not just because they're worn down, but they don't have the immune surveillance anymore. We need to monitor what actually happens when we give the drugs to the patient. We need to understand that toxicity is far, far better than today, and there's some oncopolitical politics. One of the most important issues is that no patient should die without us having learned anything. It's the worst tragedy to lose your child, but then knowing that you lost it and medicine haven't progressed in any way because we learned nothing is really a tragedy. So every patient needs to enter research protocols, and we need to facilitate cross-European data and knowledge sharing. So if you take a child that at some time of his life suddenly get a clone, a malignant clone in his body, and it expands, and we need to understand the etiology of that. We need to understand the tumor biology, the better therapy, how the drug works in the body, novel approaches to improving therapy, understand the toxicities. In the end, the patient gets cured, and what about the late effects? And if we look at how the cancer biology in itself influences these, or the tumor genome, of course it influences tumor biology and therapy and the way we construct our phase 1 and phase 2 trials. But the host genome plays a critical role in cancer etiology, in the way we have drug disposition, and the toxicities and the late effects. And in combination, of course, they affect the efficacy of our therapy and the cure. So there's two partners or two players on this stage, and we need to integrate those, and we are only at the starting point of this. So what are the tools we can use? And each researcher you talk with will have exactly the right tool to make the car running. The basic effort is we need to integrate that across disciplines. And that integration is to a wide extent lacking. Each of us publish our own best research, but how can we integrate all the data? So we have an obligation for some kind of big data composition. But in order to understand this, we need to understand what is making us as we are. If you look at identical twins, in themselves it's fascinating to see two copies of the same genome, the same individuals. If we look at it from a medical point of view, if you give two identical twins exactly the same therapy for a specific disease, it can be a cancer, what we often see is their blood concentration of chemotherapy is exactly the same. They get thrombocytopenia or hair loss or complications at exactly the same time point, and they regenerate after chemotherapy in the same order. So it's really very deeply genetically controlled. But if you look at these two American guys and these two British girls, they're very different. They're different because of their genome. So the book, the telephone book, or the Bible you have inside your body consists of 3 billion letters. They're matched in a specific way. So every cell you make in your body, and as I talk, you make in the order of 200 million cells per minute. Each of you make 5,000 kilometers of DNA per minute. If we took each of us and entwined or took away the DNA and bind it together just from one body, the DNA will stretch without us changing it from here out to the sun and back again 450 times. Doesn't it go wrong from time to time when we copy all that DNA to make a new cell? Of course it goes wrong. That's why we're here. That's why we are not single-cell organisms. With every cell division, we make approximately 3 new mutations. That is perfect. That is why we are so diverse and life is interesting. That is also why some of our patients respond different to therapy. If it occurs while we were made by our father and mother in the germ cells, every single cell in a new individual will harbor these mutations. If it occurs after we are born in what we call somatic cells in our body, it may initiate cancer. So it's not a surprise that cancer occurs because that is part of the evolutionary game. We make diversities and those who are the best in some way will survive. We went from cells to microorganisms to animals and to humans in the end. So there's a price to pay for this evolution. It doesn't mean we cannot cure every patient, but it may mean that we cannot prevent every cancer. So we can look at how are all these variants and at different time of our code, approximately every 300 letters of these 3 billion letters is different. That's why Martha and Jill and I, we look different. Good or bad? So these markers is a marker of our genome. And we can map these markers for a reasonable price, and then we can link it to various diseases. So we have a very broad scale of issues. At the one end, on the end of the scale, we have these small variants, and we have up here, don't want to go through all these genes, but we have a group of variants that are rather common. From a few percent to up to 50% of the population carries these variants, and some of those will have an increased risk of getting a cancer. But it's only a double risk. So the risk goes from 1 in 3 to 400, perhaps to 1 in 200. Still, 199 of these 200 will not get a cancer. But at the other end of the scale, we have what we call syndromes. These are individuals that have such a propensity for developing cancer because of the genome that it's likely they will that during childhood or during their adult life. So how should we understand these syndromes? Here you have an enormous amount of cell taken from a random individual. Why does spontaneous cancer occur? Why did any of children get cancer at all? Well, sometimes, as I said, when this code of DNA are copied to a new daughter cell, mistakes happen. And they happen randomly. It's like you read a book, it's very interesting, and on page 70, one letter is changed. You can understand the crime novel anyway. You know who killed the butler. It's just one letter. But sometimes this letter is critical. Now the individual in the book is not called Anna, but Anne, which is a completely different person. So sometimes very radical changes occur by a single mutation. But that's okay. There are plenty of normal cells around. And sometimes even much more rarely, the next mutation hits exactly the same spot. And we have 2 chromosomes, one from our mother, one from our father. If the same critical gene is hit at both, suddenly that cell will start to function wrongly. What if you have a cancer predisposition? That means you're born with the first mistake in every single one of your body cells. Which means that any time the alternative mutation on the other chromosome occurs, you have the propensity for developing cancer. And that's why these cancer syndromes, the hereditary cancers, are often familial. The age is much younger because it's more likely. They're often bilateral tumor or multifocal tumors, and these patients more frequently get secondary cancer. So now clinical geneticists have said, we can use this in the clinic. The best thing is to sequence the whole genome of a patient, but there may be a shortcut, at least for some of the patients, to that. If you have a specific family cancer history, if you have a specific cancer that indicates here we very often find syndromes. There are more than 60 of those symptoms today that we know. So if you have cancer of a specific type, it can be a brain tumor, it can be a leukemia, it can be a solid tumor. When we see that, we often think there could be a predisposition here. Sometimes the tumor genetics, when we study the cancer cell itself, is so strange we know there must be a syndrome. Of course, patients that get several cancers, some patients that have other developmental mistakes, their cognitive development has been impaired, they may be short, and so forth. And some patients that have very excessive toxicity for therapy. These are the 6 markers where we tell physicians, here you need to consider whether there's a cancer predisposition syndrome. And we mention this form because it's very useful, because routinely we normally say cancer occurs randomly, and if your child has been healthy so far, don't expect that it has a predisposition, or there's a family here with a predisposition. And facial looks, things like having a short thumb, it may be hyper or depigmentation in the skin, those subtle features can be an indication. And we need to teach our colleagues and ourselves when to look for these syndromes. And when we take and explore a large cohort of cancer patients and sequence their whole genome, we see patterns turning up, as Jill said before, around 8 to 10% of childhood cancers and 10 to 15% of adult cancers are due to dispositions they are born with. For the childhood cancer, what we call the TP53, that syndrome is the most common one. In adults, it's very common to have mistakes in the BRCA gene, which cause, among other things, breast cancer in women. But we also find that sometimes these cancers that we didn't relate to childhood cancer, some of the cancers that adults have, we sometimes realize that have mutation in the same genes that now seem to be more frequent in childhood cancer. Another aspect of what Jill emphasized, we need to learn from the molecular biology and not just by the phenotype. It doesn't matter really whether it's in the breast or in the lungs or in the bone marrow. The pathway affected may very well be the same. So these gene sequencing studies are moving us forward to a deep understanding. And my guess is that if we look 10 years ahead, 20 to 30% of all our children with cancer will have a known predisposition. It plays a role for how we're going to follow those for the future. So what are the pros and cons to try to explore extensively the human genome in a childhood cancer patient? I think it's good in the first consultation to sit down and in detail discuss with the family, why did this child develop cancer? Because that is on the heart. They're afraid of losing their child, but they want to understand the why. And sometimes when we sequence the whole genome, luckily most cases, we don't find any indications of a syndrome, and that is very reassuring for parents. But if we do, we need to offer these patients and their families cancer surveillance. And we may learn, just by having this deep insight in the human genome, we may learn about other associations. These associations can be somatic, but even the way we think, the education we can manage, the way we organize our lives can be influenced by our genome. And ultimately, my hope is that if we look 10 years ahead, we will have integrated this knowledge into the neonatal screening programs. Today we screen for metabolic disorders and other diseases that are far rarer than some of these cancer syndromes. And it could be providing survival benefits if every child was known to have a specific risk or not. It's not been very well studied, but it has been addressed. And I'll come back to that in a moment, but there are some arguments against, because we also find things we were not looking for. Most of you in this room will, I feel healthy. And do I really want to know that I have some kind of predisposition for a disease I didn't know about? Because it will affect my life. It will affect uncertainties about my health. So there are a lot of ethical, psychosocial, and somatic issues that needs to be addressed. And we can only address those by very close interactions with patient and family groups. And of course, for society as a whole, there's some healthcare costs that needs to be addressed. And we were very conservative previously, but that has changed and is changing as we talk, because recent surveillance studies of families that had such a cancer predisposition syndrome have supported that if we look 5 years ahead, those that were provided with a surveillance program for cancer had a 90% cure rate compared to only 60% for those who opted out. that decided not to have that surveillance. And if we look at how these cancers were identified in these individuals, certainly clinical examination, just taking the patient in every 6 months or every 12 months and examining the patient, was beneficial, but most of the cancers were detected due to the surveillance by imaging or by surgery. These will have, of course, a health issue burden by suddenly knowing that I'm not cured just of my cancer for the rest of my life. I need to go through those programs. But it's not really different from patients with diabetes or other diseases going to their GP every so often. Among older adolescents, we today recognize that 15% have a chronic disorder. It may be a lung disease, or disease in the bones or the joints, some neurological disease, or it could be a cancer predisposition. Basically, they're no different, and I believe the patient can handle this. That's in some way the easy part. We can do that detection and implement it in the healthcare. The difficult part is the bioinformatics. The amount of knowledge that comes out from this research is very extensive, because we're not talking about the 3 billion genes only, the 3 billion base pair only. We're talking about we need to make hundreds and hundreds of copies to read it in depth. So we end up in, when we start with 100 billion letters. This is Charles Dickens' Bleak House in almost 1,000 copies. I mean, who can read those many books? Well, we have machines that can do that. So we could boil it down, align it to the normal genome, find out the variants, what are frequent, what are in relation to the known cancer predisposition genes, and then in the end, we may stand with hopefully 0, but sometimes a few variants that we say it could have played a role. And we cannot in Denmark, we've started a program in Denmark to do that, but we cannot in Denmark do that by ourselves, because we need study power. That's why we need on a Nordic scale to study that, and even on a European scale to study it. A practical consequence of this sequencing is not just finding those who have a predisposition, it's also finding those who have a specific drug disposition. Their medication and the way they deal with the drugs are different. So we have perhaps 40 to 50 drugs that we use frequently, occasionally in pediatric oncology, and they will all be handled differently from each of our patients. That will influence the way the drugs work to cure the patient, but also all the toxicities. I'll just give you one example here. One of the most common drugs, methotrexate, is given intrathecally to the brain. It's given in high dose and an oral therapy. Developed 75 years ago, and still an extremely efficacious drug. So we studied almost all patients with leukemia in Denmark during a almost 20-year period. And we looked at the transporter protein that take the drug, it's in the blood, and put it into the cell. And we look at how well a patient cured by a variant in this transporter mechanism. So those who had a transporter that very easily put it into the cell had a cure rate of 89% compared to those who had a less effective transporter of only 80%. So these patients were receiving the same drug to the same disease, but the patients were different. And that difference causes, in one group, twice as many relapses compared to the other. We can take another drug, 6-mercaptopurine. It's a drug that's given to patients with leukemia, and we just registered in a Nordic cohort, what do patients actually tolerate? So physicians adjust therapy as they move forward. In the end, we would calculate what was the median or mean dose the patient could tolerate. And some tolerated very low doses, and some tolerated 10 times as much. You hardly go to a physician who then say, it's not good enough, and I give you 10 times the dose that other patients would tolerate. And we need to understand that in depth. A US group with whom we collaborate said, let's take these drug dosages and see how well do that link to the genome. And they found 2 variants. How they work is not that critical, but they were just 2 variants that both had a very profound impact. The curious thing is that that variant is quite common among Europeans, whereas that variant is quite common among Asians. And we're becoming a very mixed population throughout the world. So some patients will respond different to the therapy simply because they have a different ethnicity. And that's another aspect that needs to be integrated into our future work. And when you map it together and say, You can have different kind of genotypes. Your genome can have different copies of an active or inactive gene. For these two variants, the drug doses coming from this high level steadily go down to very low tolerance. So testing patient before they even start the therapy may guide the physician on how much the patient should receive. The alternative to this genotyping, where we look into the DNA to tell us which dose the patient should have, is to measure the drug concentration in the blood. We made a large study recently, supported by the Swedish Cancer Foundation, to look at the end product, what goes into the DNA and interact with the DNA in leukemic cells to eliminate the leukemic cells. This is now something that we can measure in the clinic. And we did that for a very large cohort of almost 1,000 patients over a 5-year period. 10,000 of blood samples were taken. We measured the concentration, and we could demonstrate that those patients that had the highest concentration in their blood, they had a relapse frequency of around 3%, and those patients that had the lower concentration, they have a relapse rate that was 3 times as high. Again, another example that even though the therapy is the same, the guidelines to the physician on how to adjust the therapy is the same, patients respond so differently that it influences the risk of relapse. Not because the leukemia or the brain tumors or the solid tumors is different, however much we study that cancer cell, but because the patient is different. And of course, this difference in patient have a snake in the bathtub. There is a price to pay. So every time we treat a patient, we may treat one cancer in one host, but there's so many organs. Each organ have the DNA that's the same, but it's expressed differently in all these organs. So some patients will have fungal infections, some patients will have hypertension, some patients need surgery for some kind of gut complication, some patients have muscle pains, some patients get fractures. You can pick your favorite organ, and some of your patients would have exactly those complications. And we need research to address every single one of these, because you're not in general predisposed to getting these toxicities. You have a problem specifically associated with that organ in that patient. And previously, we didn't really mention that to our patients. We said, oh, it's only a few % of the patients that get that toxicity. Now we know from our Nordic registration that 50% of our patients will get one of those. So each is different, but bound together, it's more likely that one of our patients will get one of those than that the patient won't get any of those. Whoops. Go forward. So we wanted to address that. And being a humble person, we thought, what can we learn from the other groups? So we wrote to all the groups around the world and said, please send us your protocol. We made an international consortium that went through 14 toxicities that we thought were very important for cancer therapy. 14 different toxicities. And what we realized that none of these toxicities was defined in the same way across the group. So when we in the Nordic group register patients with epilepsy or a thrombosis or a bone complication, another group in the US or in France or in Japan will register that differently. And no two groups had exactly the same definitions for all the toxicities in the protocol. So really no groups could compare the toxicity profile in general. And then no groups really targeted all the toxicities. So some groups thought, oh, this toxicity is very, very important. We need to do really research on that for all our patients. And others picked another favorite fruit. But at least in the end, what was successful was that we came up with consensus definition, a new starting point across all the study groups. And now we're making in-depth analysis of osteonecrosis, of pancreatitis, of CNS toxicities, and on thromboembolism. It's a major task because all the groups around the world need to register the toxicities for that specific one for the whole cohort. So we're talking about a background population. This is leukemia of perhaps 50,000 leukemia patients. But what we demonstrate was that it is doable. One of our researchers collected almost 500 cases of pancreatitis. In my institution, I may see 1 or 2 cases a year. How can I deal with that patient with this little experience? Now we collect these data from all around the world. 18 study groups. Here you have Schilt's study group, Fralle, Here you have Martha's study group, DCOG. Every single study group wanted to participate because they all recognized we cannot do this by ourselves. So we collected 500 cases. And just one thing that we did learn from this study that nobody knew before. What is the problem of having pancreatitis? Well, there's two critical problems. One is it can become chronic and give you pain for years and years ahead. And the other thing is you can get diabetes because insulin is produced in the pancreas. What we found was insulin deficiency, that is diabetes, persisted as long as we followed the patient. There was no change. Of course, sad information, but important to know for the families. If you get diabetes, it's going to stick on. And you need to train your child. As any other child with diabetes, this is something he needs to get used to. With diabetes schools and so forth. But when it came to the chronic pancreatitis, as long as the leukemia therapy continued, patient had chronic problems. When we stopped chemotherapy, it slowly got better and better. And 8 years off, it was gone. That is truly very important information for parents and physicians to know about. And then in the end of my talk, I just want to address one specific issue. We always talk about the patient. We talk about the tumor biology. We talk about the family. But what is most important for a child, not each after they reach school, is the interaction with their peers. We started a project a few years back we called RESPECT, which is rehabilitation, including social and physical activity and education for children and teenagers with cancer. Of course, we like the word respect, but it does have a meaning as well. And there's an educational session, part of the program. There's some physical and social activity, but the important part is that for every child with cancer above 6 years of age, they get appointed 2 ambassadors from their class. Ambassadors, they're volunteers, and say, I want to be a main support person for that child with cancer during the intensive part of therapy. The main point is rehabilitation needs to start on day 1. We don't want to lose all the capabilities the child had previously and then try to pick it up subsequently. Rehabilitation needs to start on day 1, and of course physical activity needs to be part of that. And one of our worries when we started the study was, would we have children, because some children are bullied in school, they are isolated even though they are healthy? Would we have patients that are not only hit by cancer, but not also by the knowledge that nobody wanted to support me? And that didn't happen at all. We have almost now 120 patients consecutively in the protocol, or in the study. We haven't had one single case where none in the class wants to volunteer. So how is that? Well, you could say there are 2 parameters that plays a role. One thing is, were they friends before this started? And what are their social skills? So if you have a classmate that had very good social skills, and their friendship before, we call them best friend forever. Of course, they want to be ambassadors, and they are excellent ambassadors, no doubt about that. But the important message is we have the good Samaritan as well. These are healthy children. I never played with Peter or Anna. But I know now that they've been hidden by cancer, and I want to be a supportive person. New friendships are formed, and because these are the strongest peers in the class that volunteer for this and are elected by us, suddenly these previously bullied or isolated children, when they get cancer, become supported by the strongest in the class. And that's a major change of their self-perception and a facilitation of going back to school subsequently. So in conclusion, survival is of course not the goal. I think it's fine that we state how can we reach 100% survival, but that is not the goal. It's often achievable with current therapy, but normality is the goal. And we need to preserve that normality. And we need to find new ways. The respect is one approach, but everybody needs to think about how can we engage society in providing the support that makes it easier for the child to go through this strategy or therapy. And of course, we need, for those where it doesn't work, the treatment, to find novel treatment approaches. And this will require genome-wide analysis. It's not really that expensive anymore, so it's feasible, but the bioinformatic to interpret all these letters, like taking the Shakespeare and just mixing up the letters and try to write the novel again, that is the complicated part. But we know it influences cancer predisposition, it influences treatment responses, including toxicities. And if we can find predisposition, we may have surveillance programs that can detect the cancer at an early stage where it's still curable. Every child with cancer will in the end come to the hospital, but sometimes at a stage where you cannot really address it in a curable way. So pharmacogenomics from the genome is critical to improve therapy, but that's only the medical part. The psychosocial part is also to find new ways. Martha had a lot of excellent proposals on how we can map how these families actually fare. We need to get novel ideas on how we can solve the challenge they have. Certainly the families need support, but so does the network the child once was part of, to be part of that again after the therapy. So thank you.
Thank you, Kjeld. We might have time for a very, very short question. Okay, if not, I think actually we will thank you and continue with the panel discussion. Thank you again. So now I would like to invite the other previous speakers up here. Don't do Jonas Abrahamsson here. On the NUFO meeting a couple of days ago, we had a speaker who actually fell off the podium, so don't want that to happen again. So now we will have a panel discussion, and now we have two additional participants. It's Professor Per Kågner from the Karolinska University Hospital. There, good. And Per is an oncologist and an expert in neuroblastoma. And we also have Per Leander, who is the Secretary General of the Swedish Childhood Cancer Foundation. So welcome all. So now we are going to discuss a couple of topics. And the aim is that we will now try to figure out what we can do more to reach 100% survival and with a high quality of life that you all have been talking about. And we will start with the first question here. And I would like to address it to Per Kågner. Mm-hmm. Yes, and this is actually a topic that Gils has been talked about already, but I thought that we might elaborate a little bit more on it. So children don't get access to the latest cancer treatments, and that can be read, for example, in the 10-year report from the European Medicine Agency. New cancer medicine are often developed only for adults, thereby omitting or considerably delaying access of these drugs to seriously ill patients. We heard that that was the case in Europe, and I wanted to ask Per Kågner, is the situation the same in Sweden? And what can we do about it?
Definitely the situation concerning kids are similar in Sweden as in the rest of Europe. Of course, it's not the same all over. We know that some kids might have, due to chance or due to active physicians or active researchers, all of a sudden access to a dramatic, good drug, while others wait and wait and wait. Mm. So we have access in terms of diseases. It's difficult for drugs to get for children with certain diseases, but also access for kids. I mean, if we have a drug for neuroblastoma leukemia, does not mean that every child with neuroblastoma leukemia can get the same treatment, because it depends on where they are, how they are investigated, and where they are in terms of protocols, in terms of clinics, in terms of different situations.
Mm. And how do we do it in Sweden? Do you clinicians talk to each other over the country and try to find trials that the patients can participate in, or how do we do it when we are now going to cooperate, as Gilles said, in Europe, and how do we do it in Sweden then, in the beginning?
We have a tradition to work together. So we have national groups that meet together, have contacts, have meeting over the net, or have telephone conferences, or have physical conferences. we have collaboration. We are actually sometimes sending patients to each other, but we are also starting these new important units for having these experimental trials available for children, so they can enter novel trials, novel studies of certain drugs.
But are we looking outside Sweden as yet? Do we send people or patients abroad?
Of course, there are people, children sent abroad, but there are always barriers. I mean, it's a matter of cost. It's a matter of complications for the family and costs for the society and hesitation from the doctors. So, of course, it's always better to have it nearby, but already to have the knowledge means that we can identify patients that are able to be sent or must be sent, and families that accept that possibility.
And how often is it that the patients actually come to you and sort of want you to really to find a clinical trial that their son or daughter can participate in?
I think that the situation for us are moving very much. I mean, the situation today is not the same as yesterday. So this is for these families. I mean, 10 years ago, none in this room had seen a smartphone. We don't know what will happen 10 years from now. Families do surf the web. They know about studies. They know about treatments. And so families are often half a step ahead of their physicians.
And
can I just add one comment?
Absolutely.
To this? So in the Nordic group in Novo, we have on our website what we call the novel therapy. So every experimental trial with an experimental treatment approach that is open in Sweden or in Denmark or elsewhere is listed there. So the physician can always go in and say which trial is currently open, and then decide, well, this is accessible for the patient in case. I'm not sure whether parents can see it directly, but every physician would be able to do that. The other issue is that the reason we do these experimental therapies is, of course, to provide something to patients, but also to learn. And there's also this balance. It's important that children and families are aware of that. So if we had a drug that did work, I mean, every child would be provided access to that drug. Sometimes we don't know, and we need to go through these testing phases. And some families will feel that this child has been burdened by therapy for many, many years on various treatment approaches in the local center, and it may not be the right solution for that child to continue to travel around the world to try experimental therapy, because one thing we can always guarantee is there may be side effects. So the important thing is to have the network where if the family wants this, they have the access. But it's important that parents don't just think that, oh, there's this protocol, this is the right solution for my child. It's also a learning phase. You want to comment, Jill, on that? Because you are much more...
You're absolutely right. We need to make the information available about the trial, the site. But in addition, we need to build what we call clinical tumor board discussion. Discussion in between physicians, molecular biologists, when it is relevant, about the case of children in relapse. Because no one can say in his or her office, this is a trial that the child should go in. The discussion about what the treatment what were the treatments received by the child, what is the current situation, what are the options, what are the trials. Discussing together is very important. This is what we set up in France, and we are discussing weekly children who are relapsing under treatment. And this is a training experience, is a sharing experience, is about having on one hand the trials open and the drugs available, on the other hand the discussion that help build the proposal and assure the parents that the case of the child has been discussed by several people. And I think this is a way to implement better access to innovation, discussion about the case, and then, as I mentioned before, capacity to travel when there is a need to travel within the country or outside the country.
But
Yeah.
It's important to stress that this is still a learning phase, because when we analyze the relapsed recurrent tumor in high-risk patients, we're already one step behind. In the near future, or in many circumstances today, this is done upfront. This is done at diagnosis to understand which patients should be tailored for more intensive therapy or novel therapy from start.
I was also curious about your how you think about the pharmaceutical industry, and since it's such a sort of small population and it's not a big market for the drugs. But I heard, Gilles, you are able actually to convince them that they have to participate in this, and that's a big step forward, I guess, because just a couple of years ago that was not the case. It was difficult to get the pharmaceutical industry to participate.
Well, actually, I was not the one convincing them. You know, the politicians in Europe voted a resolution which says better medicine for children. And this set up a completely different regulatory landscape in which the company had to consider their drugs for children. What we did is we said, okay, they don't know how to develop drugs in children. And we don't know how to develop drugs as a pharmaceutical company because we have not doing that for the last 50 years. So what we set up is working together. Because as you said, we are dealing with a very rare population, which means that we need to make the best choice. And we need to integrate the concept of development of a drug with the intent of registration into the standard of care of patients. So what we build is this partnership and telling them, you don't know, we don't know either, let's learn together and improve the way we are doing it.
That I think we can take the next question because that relates to that. And then that is about the prioritization and coordination of clinical trials at the international level. And you talked a lot about that also. And I was a bit curious that who is actually going to do this? Who is going to decide which patients and what trials and what drugs should be tested? And how are we going to organize? Cooperation, of course, we have to do that, but someone has to decide.
Oh, sure. I can start and my colleagues will continue. In Europe, for the last 50 years, we have European clinical trial group setting up clinical research in a given disease and implementing frontline therapy and phase 2, which means that a child in Europe with leukemias will either receive the NOFO protocol or the IBFM protocol. A child with a neuroblastoma will receive either the Cyopen protocol, many countries, or the German protocol. So children are not treated by a physician in his office with drugs, participating to well-coordinated, well-established frontline clinical trials, which is a way to give quality, which is a way to give equal access, and which is a way to generate meaningful information in a safe and secure environment for the child.
But as you said in your talk, that there might be like 5 companies developing the same drug towards the same target. Who to choose between them? Because there are a limited amount of patients. You can't do all of them, as you said.
So what is important is to keep in mind that we have 2 settings. The newly diagnosed patients participating frontline clinical trials. And most of the treatment at the moment are the ones setting up by academia, and there is not many sponsored trial by industry frontline. And then the setting of the relapses, patients who failed initial therapy, and this is where most of the clinical trials with drugs from pharmaceutical company are being developed at the moment. And the question I mentioned is clearly, we cannot develop 6 ALK inhibitors in pediatric malignancies. Not all these 6 are different. Some of them are different. So we need to generate information to choose the best one and tell the company, your drug, there is no need to go forward. While your drug, you know, this is the right and you should be developing. So this prioritization is based on science, need, and feasibility. because no way to develop 6-ALK inhibitors. But at least 1 or 2 would be great, because otherwise we will be in a situation that for the last 50 years we are using drugs off-label. You know, treatment of leukemias have been done with using off-label drugs quite successfully. This is what we want to avoid.
You sound optimistic, so I guess that you anyway think that we can accomplish this with the prioritization.
We must be optimistic, otherwise we change our job.
I agree. I wanted to move a little bit further and actually turn to Per Leander and ask you, what do you think that the role of charities is in the future, and what can we do, for example, at the Swedish Childhood Cancer Foundation, to help clinicians and other people to actually reach 100% survival, high-quality survival?
I think one of the important things and what I'm standing and feeling inside is to be impatient. Not be satisfied that it's happening and not be satisfied that it feels like it's okay, but to be a pressure to get it to happen faster and quicker. And I mean, we have to work together with all the scientists, we have to work together with the society as well. But I think it's also important that we have the free money or the pressure to give air to different incentives, or initiatives rather, that makes us take a better step forward. And I think that's one of the roles we can make really today and even more tomorrow. And I think the role of our kind of organization will grow, because I'm afraid that the commercial or the drug companies will not be that good that they're working for this for free. They will try to avoid the regulations as much as they can, I'm afraid to say. And government, even though they have lots of money, they have lots of holes to put them in as well. So I think it's important that we can push for new ideas and be empowered to new developments and make it be quicker and faster and take help of the general public that support us with money.
What do you think? What could we help with?
Well, it's absolutely true. And we need co-funding. We still need Europe and national grants to support this. But we need funding from charities, as you saw on my slide. Because otherwise we won't get the capacity to start and run this. So this is why I think in the future the role of charities in supporting these developments, the science, making sure that across Europe 3 out of 4 children in relapse do have a molecular profiling, their charity will play a major role to speed up and accelerate the way we are developing innovative therapies for children.
Martha?
Well, I would like to plea also for the charities to devote money to psychosocial research.
Absolutely.
Yeah, I think we all agree on it, but it's not that visible yet that considerable amount of money goes to increase this kind of research. And I think I should hope that it will be different in the future.
I think we need to recognize that in order to cure more patients in any single country, you need the study power. Many of the research trials we're running requires at least hundreds of patients, sometimes 1,000 patients. No country can provide that. So the only way any childhood cancer charity organization can support their own patient is to secure that these patients are part of a strategy that have the sufficient power to demonstrate how should the future treatment be. And so it's not just putting away money to other countries, it's really securing that the data that comes out is reliable for our own patients.
So we should choose choose better what we give the money to. Sorry.
And also to cooperate. I think that's very wise that to be more between our charity organizations, but also together with the clinicians and different initiatives that are growing up now, I would say.
I mean, a very good example is childhood acute myeloblastic leukemia. If we go back 15, 20 years, the cure rate was like 25-30% in Sweden. Now it's beyond 70% with exactly the same drugs that we had at that time point. It's only because we had collaborated. It couldn't have been done in Sweden as itself. When it comes to the novel drugs, it needs to be studied on a European basis. You can only help your own patients by making them participate in this very large collaboration.
Another illustration, if I may, is the quartet project that I briefly mentioned. The need to have a system for across Europe provide access to quality assurance for radiotherapy. This is a European project developed with the ORTC, and it is financed by the foundation from Luxembourg, who felt that it was important to do this across Europe and generate data to learn more how these therapies on the long term would induce sequelae. So I think it's an illustration that we can really have cross-Europe program, in addition to facilitating access to innovation, a cross-Europe program to improve the way the research and the care is being done in Europe.
And maybe the churches can help there in
Absolutely,
some way. Yeah.
absolutely.
Adam?
I think it's a very good example of charities like Barncancerfonden who have dual or several responsibilities. You have raised a lot of money for research, which is very important because academia has been leading in research when others have not raised the money or been interested. But you are also using your possibility to give information and have an impact on stakeholders that take important decisions, like companies, like politicians. So I think that you can do much more than what doctors and researchers, because we are often claimed to talk on our own sake. It's important that you talk for the patients, because you can listen in many directions and also speak in many directions. That is very important.
We take that with us. And another topic that we usually talk about quite a lot is the centralization of diagnosis, treatment, and care. Is that a good or a bad thing? And we have Martha here, who has some experience already in the Netherlands. Can you draw any conclusions yet?
Well, we just started, so it's hard. I explained this morning in a Novo session that we are lucky that our country is rather small in distance, so centralization makes sense, because if you centralize in a huge country like Norway, still families will live very far away, which the distance is difficult. What I think, if I look from my perspective, from a psychosocial perspective, what I see in the Netherlands, with the different centers, there's a very different approach to the money which is dedicated to psychosocial care, because we are not being paid by the healthcare suppliers. So it depends on the hospital what kind of money they think is appropriate. And so we have hospitals without psychosocial or with limited psychosocial care. And one of the advances of a centralized system is if you put more dedication to this, this part will be definitely better. So the centralization in that way, quality of life, I hope will improve significantly. And what we see in the Netherlands already, patients, for example, neuroblastoma patients are now already being treated centralized, and there is all experts from the Netherlands are around the table working together. And I think we already see the benefit of this.
What do you think, Per Kågner? Is it a possibility in Sweden, or is it too difficult here?
I think more important than talking about centralization is talking about coordination and collaboration. Because if we identify which things must be, or what efforts must be centralized, then we can see that there are other things that can be coordinated. I mean, we don't have to send patients to have one machine that sequences DNA. We don't have to send patients when we discuss patients' histories and decide upon treatment. So it's not necessary that family travel around the nation or travel around the globe. Data and information will travel around the nations and the globe. And that is essential, that we share information and we share decision making. And using novel techniques can allow us to do so much better. And then sometimes patients or hands must travel to get the best out of, let's say, manual treatment.
I think we need to distinguish between what we could call standard of care and novel approaches. When it comes to standard of care, any center can do it because we can describe exactly what needs to be done. You can have it as a shared care system where every center can work independently. But almost for every patient, some things occur that wasn't expected. Whether it's a toxicity, insufficient response to therapy, a relapse, and you need these tumor boards. And these tumor boards need to be governed by people that have the best experience. Not every physician can travel to every meeting. And I think for a country, you need to appoint those who you want to lead the way. And once that is established, that this is the new standard of care, of course, every center can provide that. But we shouldn't have centers that keep their patients just to be as good as the other ones. So I think shared care for a number of issues are the solution, but sometimes you need to centralize. And not that you mentioned surgery, not least surgery is something where the patient numbers is too few in the Nordic European countries to distribute them throughout all centers. And it may be even for some patients that several countries need to get together to get the best facility for the sake of the patients.
Gilles wants to say something?
Yeah, I can say something, absolutely. At the moment in Europe, there are approximately 350 centers treating children with leukemia or solid tumors or brain tumors. There are more than 60 different diseases, and the treatments are complex. So not all the 350 can deliver in all the disease the entire treatment for a given child. This is why what you both mentioned, the organization of care, which part of the treatment can be done locally, which part of the treatment should be done in a specialized center, which part of the treatment could be an even hyper-specialized center, is the way to be sure that children do have access to the best treatment at the moment. Liver surgery is extremely complex in children. Cannot be done by all pediatric surgeons. There are only few in Europe who can do that because there are operated quite a number of children with hepatoblastoma, which remains rare. So this issue of shared care, organization of care, defining which part of the treatment can be delivered where, will assure across Europe that all children can have access and will travel when there is a need to travel and will stay locally when they can stay locally.
Everything comes back to collaboration, right? Yeah. We will have one final topic, which is something completely different. I would like to talk a little bit about artificial intelligence, which is a sort of a hype or biggest potential ever. Depends on who you talk to. And I wanted to show, I think I can show a little film to set the background.
Hey, Cortana, what's the meaning of life?
We all shine on, my friend.
How are we supposed to shine on when we're so busy just trying to get stuff done?
Artificial intelligence can help. For example, I can give reminders and updates so you can focus more on what's important to you.
Your AI, Cortana?
Yes, people are already using artificial intelligence for all kinds of things across all kinds of devices.
It seems like we've dreamed of this forever. Why now?
A combination of advances in data, algorithms, and computing power.
Okay, but how's all that translate to intelligence?
The digitization of everything from photos to health stats is creating unprecedented data sets. Breakthroughs in machine learning algorithms make it possible to process that data, and it's all powered by computing advances on the devices you use and in the cloud.
Wait, machine learning? How do machines learn?
You can feed a program thousands of images tagged as cat. The program sees patterns and teaches itself to recognize subsequent untagged images of cats. And people can apply that same model to almost anything. Medical records, genome images, text, speech, agricultural data, and more.
So AI is moving from just seeing and hearing to cognition and reasoning?
Yes, with the help of deep neural networks.
Neural like nerves? A brain? What's a deep neural network?
Neural networks process information in a similar way to the human brain. A large number of interconnected data processing elements called neurons work in parallel to solve specific problems.
Huh. Crazy. Then where does all this go from here?
Scientists and engineers are using AI to change the landscape of transportation, reinvent healthcare, and transform business in ways that will make us all more productive.
All of us?
Yes, people will use AI to unleash human potential and creativity.
Can you give me some examples? AI is constantly evaluating weather, soil, and numerous other variables to help farmers optimize their crops. It's already increased yields by 30%. Using facial and emotional recognition to identify distracted driving and alert the driver to the risks in real time. Developing algorithms that discover and exploit weak links in HIV, the common cold, and cancer. Oh, maybe we will all shine on. You're the best, Cortana.
I'd blush if I weren't a seamless string of binary numbers.
So, what do you think? Is it a hype or the biggest potential ever? What if the cat is actually a pathological slide that could see and read cancer, find cancer cells faster than a pathologist? Kjeld.
Okay, so I think there's two issues that we need to separate. One thing is using various kind of IT platforms to convey what is already known, because the field is becoming more and more complex. I mean, just the time you need to spend on the internet to find the data you want to look for, you know it's there, you need to look it up. That's one part of the issue. So taking broad knowledge and put it in. The second thing is to find patterns in the data set that we have. And surely the machine learning algorithms and neural networks can do that, but subsequently you want to have the validation. You can take hundreds of patients and find a new pattern, but you want to treat the next patients. So however much the machine learning provides of data, we need to make formalized studies that tell us which patient responds and how well. And the requirement for that is that they have the data to work with. So you can take all the data you have, and you cannot guess what the human genome looks like. So in the end, it's also a question of collecting more and more data on the patient as they're treated. And there are a number of areas today where we don't collect those data. Most patients dying of cancer in Europe don't have the genome in the tumor or in the host sequenced. So unless we move forward and say the first step is to provide the data, both how the patient in the tumor looks and how the patient responded, and the toxicity, the machines will have nothing to work on. And I think that's the next step, to take the tools we have today to generate that information. Then we can be much better in predicting, for instance, which drug Jill should put into his trials.
Well, I see benefit for data collection on a bigger platform, as was talked about after my talk. So I see benefits because we can also predict more, and there are becoming questionnaires with predicting models. So you need less questions. So if we have less questions, we can ask patients and parents. That will lessen the burden of questionnaires, and if we can use more questionnaires with less questions, we can improve the field.
Mm-hmm. Any other comments?
Artificial intelligence is important. I mentioned in my talk that through the process that we are running in ITCC, by the end of 2018, we'll have 1,000 exomes from tumor of the patients at relapse, which is a rather unique set of data. One exome is roughly 1 to 2 giga, so we are dealing with large, big data, even fat data, as they say. Having artificial intelligence to explore this, well beyond what we can do at the moment in bioinformatics, would be extremely important to identify what I called new target, new pathway, and so on. And this is why we are trying at the moment to get access to this artificial intelligence with big companies, IBM, Palantir. I can tell you it's not so easy, because these deep learning programs are extremely expensive. So we are trying to convince them that it is worth considering providing this free in the field of pediatric cancer, just to advance and accelerate learning. We're not yet there, and maybe we will need some input from everyone telling this is what we need. All the data we are generating, and I hope in the near future we will have all patients in Europe having all genomes of their tumor and their host. And there we need this deep learning to learn. It doesn't mean that the machine will make the decision, but we'll provide the tools that we can make the right decision in terms of treatments, in terms of care, and so on.
The artificial intelligence is good, but we need the real intelligence as well.
Yes, absolutely.
Yeah. Okay, Pat.
Of course, AI is a hype. As always, you try to label any technical development, it's always tend to be a hype. But I think for sure, the technical development combined with cooperation and lots of thinking will do the future that we can reach our vision.
So in summary, a little bit hype and a big potential.
Absolutely big potential.
Okay. So, wrong. I think we will finalize here with lost slide. I want to do just now 30 seconds each of you, because we have reached the end of this panel discussion. 30 seconds to tell what is the utmost important thing, the most important thing that we have to do to get towards 100% survival, high quality survival.
I think I'll repeat what I said previously, that no patient should die without us having learned something. And I think that since if we talk about Sweden, the Childhood Cancer Foundation is providing so much support to the Swedish center, I think we should put a standard on what we need to learn for each patient. It may be on psychosocial issue, it may be on the host genome, it may be on tumor biology, but I think you have the, you could say, power to enforce that every center provide a minimal requirements. Today we do see vast diversity throughout the Nordic region, throughout Europe, but also within the single country. And it's, in the end, only sometimes a carrot, but sometimes a stick that move pediatric oncology to the forefront. So there are minimal requirements that we fulfill for every single child, research-wise.
By Kogner?
There is, of course, a link, a chain where all links are important. But
you can just choose one.
But we're talking about this translational research and clinical collaboration. So we raise new knowledge, we use the knowledge to improve together.
Martha?
Well, I think I shared it during my talk. Together is also together medical, psychosocial. There need to become more programs on monitoring and screening throughout the trajectories, and they should be developed in combination with the team. And I think, following your suggestion, more trials should have questionnaires, pros as add-on studies. We have not done enough in that area yet, so we have a lot to achieve. But more together, also on the level in the hospitals, between the holistic approach. I think holistic is very important.
Vince?
So to reach 100%, we need more research, and we need a significant increase in equal access to standard care and innovation in the partnership I mentioned. And we will approach 100%. I don't know when we will reach, but we will approach.
Paliander?
I think if I should only pick one, I think the important thing is to dare to always think in new directions. And I think the panel proved lots of ways of doing that. So I'm quite convinced that we'll reach that.
Okay, with that, I want to thank all the participants in this panel. And I would also like to thank the audience here and the audience on the internet, and also the personnel at the Childhood Cancer Foundation, especially Jonathan Svensson, who did a lot of work here. Thank you all for participating, and I want to welcome you back next year. A final and the most important thank you I would like to send to all the donors that give the money to or raise donate money to us that we are in big need of to come further and to be able to do more in this area. Thanks a lot and welcome next year.